live stream. The meeting is being live streamed. اعمل ايه؟ جوت ات ولا ايه؟ طيب شوف كده اتصلت. ما انا غلطت ظهر ما دخلتش اسم جروب فمش عارف اعمل ايه لايف. اعمل تاني؟ طب انا بعيد تاني. احنا على البيج مش جروب صح؟ Ladies and gentlemen, today we restore back our scientific activities after Christmas vacations. I'm glad to see you again in this series of webinars I'm organizing as treasurer of the World Federation of Neurosurgical Societies, WFNS, in collaboration with the Egyptian Society of Neurological Surgeons and the Continental Association of African Neurosurgical Societies, the CANSU. I'm glad to tell you that with my team, we organized already 56 webinars. Many of these webinars were educational WFNS Symposium. Today is webinar 57. We have the honor that this webinar is an educational symposium, and it's organized in collaboration with the Education and Training Committee of the World Federation of Neurosurgical Societies. In this occasion, I would like to thank my friend, Professor Luis Borba, for the opportunity to have such wonderful collaboration. We will organize a series of webinars with the Education and Training Committee on a monthly basis. First of all, let me welcome all our distinguished speakers and moderators. I will go by the order by which they speak. Professors Aaron Moshara, Tito Perella, Nelsi Zenon, Albert Sofianov, Manas Panigrahi, Sergei Gorly-Shift, Abhaya Kulkarni, and Frederick Boop. I would like also to welcome the moderators, Professors Joachim Ortel and the Grottenhaus, and Mahmoud Qorashi. Thanks to all of you for contributing to this neurosurgical activity and for giving us much of your time sharing your knowledge and experience with young neurosurgeons, especially at this difficult time of COVID-19 pandemic, is well appreciated. Our program today consists of 3 sessions. In each session, we have 3 speakers. For each speaker, 15 minutes. And we have discussion at the end of each session about 10 minutes. We kindly request our distinguished speakers to be committed to the time allowed, which is 15 minutes, in order to taking into consideration the difference in time zones between different speakers in different continents. I'm glad to tell you that until yesterday, this webinar is fully booked. We have 1,000 registrants over Zoom, as we can see from this screenshot. We're also doing live stream over the Facebook of CANS. The address is seen over the screen, and over the YouTube channel of the Egyptian Society, and over the Neurosurgical TV. In this occasion, I would like to thank John Bennett. He is actually doing a great job in promoting our series of webinars. To all attendees, we are glad to get all your questions and comments, and it will be monitored through the chat panel or the Q&A. This is the type of certificates we are offering. Remind you that this event is recognized by the World Federation of Neurosurgical Societies, and this certificate is approved by the World Federation of Neurosurgical Societies. We were putting the possibility that registrants or attendees can print certificate electronically. Now, my IT team is going to send certificates to all attendees of this event today. However, it's important to tell you that the organizing committee noticed that some participants only participate for 5 minutes, and they were asking for certificates. In order to get your certificate, please contribute to the webinar from the beginning to the end. Another important point, please register from your own email, because the name of the account of the email is going to be the name which is written over the certificate. So if you register from another email, the name will be written not correct. This is the previous webinars. We started to send automatically certificates to all our attendees since webinar 53. And as you can see, that webinar 56, last webinar, which was organized with the Spine Committee of the World Federation of Neurosurgical Societies, we had 373 participants, and certificates were sent only to 149 who participated in the webinar from the beginning to the end. Our next activity is webinar 58. It's going to be organized in collaboration with the Cervical Spine Research Society, and it's going to be held on Friday, 28th January at our usual time. Webinar 59 will be another collaboration with Professor Louis Borba, Chairman of the Education and Training Committee of the World Federation of Neurosurgical Societies. It takes place on Friday, 11th February at our regular time, and it's going to be about traumatic brain injury. An Arab Journal of Neurosurgery already relaunched, and we published 2 issues. I'm glad to tell you that we are receiving articles through this link, and the submission and publication is free, and I'm honored to be the editor-in-chief of this journal. I'd like also to announce about Bogota Congress. I think Professor Tito Perella will announce about it now too. It's very important to contribute to this Congress in March in Bogota. Another important Congress, which is the Men's Congress held in Egypt, 27 to 30 October 2022. I'm president of the Congress, and I'm glad to work with president of the Mediterranean Association of Neurosurgical Societies, the Professor Albert Delitala from Italy. All of you are invited to contribute to this important event. I'm sure it will be a good opportunity to visit together the Grand Egyptian Museum. May I wish to all of you Merry Christmas and Happy New Year 2022. Thank you very much. Now I give the mic to Professor Louis Borba in order to say his welcome speech.
Hello, can you hear me?
Yes.
Perfect. Yeah. Okay. Yes. Good morning, good afternoon, good evening to all people from around the world. On behalf of our president, Nelson Yozuko, the chairman of the committees, Professor Kenan Arnautovic, my partner, co-chairman of the Education Committee, Satoshi Kuroda, and all the members of the Education Committee, who thanks Professor Nasser and all the African Society for the opportunity to be here today to participate and to spread this knowledge around the world. Do you know Professor Nasser and our members of the committee and people that is participating here? When we start the idea that the new education committee, a lot of people talk about, let's talk about complex pathology, future, genomes, let's talk about complex case. What you need to educate the world is from the basic to the top. And from this, from the Chile to Holland, from Mozambique to Siberia, the pathology that you have in all hospitals, in all neurosurgeons in the world can treat. We are very pleased to start our year to talk about hydrocephalus, to talk about shunts, to talk about case that every neurosurgeon in the world, you have patients like this. Thank you, Professor Nasser. Thank you all of you for the opportunity. I know that will be a wonderful meeting, and thank you again for the participation of all. Thank you, sir. You're mute. Yeah.
Microphone.
Answer, you are muted.
Thank you, Professor Luis Borba, for these kind words. I think Professor Mahmoud Khorashi, president of CANS, is already joining. Can you say some words, Mahmoud, before we start the scientific sessions?
Thank you very much, Nasser. In the interest of time, I'll keep it very brief, and I'll say how impressed we are as CANS for the great work that Nasser is doing and collaborating with really the galaxy of the globe's neurosurgical stars, and he manages to bring them every time. And I think he's tireless. And from all the member societies of Africa, across Africa, it's young neurosurgeons, it's trainees. I feel obliged to say how grateful we are for this superb series of webinars. And as Professor Luis Borba says, we have been talking about more the complex as well as the non-complex, and it is appropriate that one of the main issues that troubles our units and our children in Africa is hydrocephalus, and you've decided to start with that series. Thank you again, and we're looking forward to a great webinar. Thank you.
Okay, thank you very much, Mahmoud. Now I give the mic to Professor Andy Grottenhaus, who is going to be the moderator of the first session in order to start the scientific lectures.
Thank you, Nasser. And well, for me also, it's a great pleasure and honor to participate in this and see so many friends, I can really honestly say, here in this, and then so many participants. One small request to all the participants: when you're not speaking, could you please mute yourself, because otherwise we get echoes in the presentations. It's my pleasure to start this webinar with the first presentation of Professor Musara from Zimbabwe, who is there, and I hope you can already share your screen, Professor Musara. I hope it will succeed, and he will talk on preventing shunt infection in a low resource setting. Please go to presentation mode, full presentation mode. Professor Musara, I can't hear you.
Okay,
yeah.
Can you hear me now?
Yes, and please go to presentation mode in the right lower corner so that we have the full screen.
Okay, thank you.
We see your second slide, Professor Musara, but I don't hear you and I don't see the presentation mode. I hope it will succeed.
Okay, let me try again.
You can go to the lower edge of your screen. There is this. Yes, now we see the introduction. Got it. Yeah, perfect. Thank you so much. Please go ahead.
Okay. So thank you very much to the organizers, the WFNS Education Committee, Professor Nasser, El-Ghandour, and the CANS team for this opportunity to talk about preventing shunt infection in a low resource setting. In this, presenting outcomes of a study we carried out using ipovidine iodine in the prevention of shunt infection. So hydrocephalus is the most frequent neurosurgical problem encountered in children worldwide. And VP shunt is a common procedure done for the treatment. And the improvement in the quality of life after shunting is often subdued by significant failure rates, as well as complications from malfunction and shunt infection. The reported risk of early infection after shunt surgery ranges from 1 to 20% in various series. And the cost of managing shunt infection is both a cost to life and a huge financial cost, and hence the need to improve on the prevention of shunt infection. So this presentation is of outcomes of a multi-center study on pediatric hydrocephalus on the use of ipovidine iodine in the prevention of shunt infection. And ipovidine iodine is an antiseptic product developed in the 1960s, commonly used for skin preparation before surgery. So this was a follow-up study to a smaller study presented as a poster presentation at the 36th annual meeting of the ISPN conference in 2008 in Cape Town, South Africa. So in this CAN study, this was a multi-center prospective descriptive cohort study for children under 5 years requiring VP shunting, and it recruited 209 participants. The children were recruited from 3 centers in Zimbabwe, Namibia, and DRC, and he prospectively observed and he followed up from admission through surgery to 3 months post-surgery between 2013 and 2018. And operations for VP shunting were performed strictly under the outlined protocol as follows. Shunts were done in the mornings, and neonates and infants were done before the older children, and the rest of the patients who may be beyond the operation list for the day. No shunts were done after an operation for an infection, for a known infection, and patients were shaved with razor on the theater operating table. Patients' chest, abdomen were prepared, and the scalp, the shaved scalp area were thoroughly washed with warm water and with 7.5% surgical scrub to remove gross contamination. 2 by 10% ipovidine iodine solution skin scrubs were done before draping, and no plastic drape was made use of. So a third skin wash was done again with 10% ipovidine iodine, and intermittent application of the ipovidine iodine after every 10 minutes was done on the wound, as well as immediately after incisions to keep the skin moist. And prophylactic antibiotics were given at induction of anesthesia. And whenever possible, efforts were made to limit the number of incisions to just 2. Double gloving and change of gloves prior to handling shunt hardware was also done. And shunt opening was delayed until the time when the shunt is about to be inserted. Meticulous and minimal shunt handling was maintained, and whenever possible, use of instruments was done for the shunt handling. Abdominal catheter was pulled down from the scalp into the pre-fashioned subcutaneous tunnel to the abdominal incision. And when it came out on the abdominal end, it was wrapped in sterile towel, avoiding contact with skin. The ventricular catheter was placed to the ventricle, and a CSF sample was collected for testing for possible infection, and the connections were then done for the shunt. The abdominal catheter was assessed for flow, then immediately implanted into the peritoneal cavity, being removed from the covering towel with betadine. Hemostasis was secured. Antibiotics were continued to day 3 post shunt insertion, and a sterile dressing was removed also on day 3 post shunt infection to change dressing. And the pressure on shunt site was avoided at all times. Dressing was changed on a daily basis until the removal of stitches. The primary outcome measures included shunt infection at 3 months, defined in accordance with the consensus group recommendations of the Canadian Pediatric Neurosurgery Study Group. And the criteria to diagnose surgical site infection followed the 1999 CDC guidelines. And operating time was calculated from the first skin incision to the completion of the wound dressing. So a total of 211 shunt insertion procedures were performed on 209 children, and these were analyzed. One male and one female patient did 2 separate shunt insertion procedures during the study period. That's why the number reaches 211 when there are 209 children. There was 1 patient who was lost to follow-up. In 90.5% of these children, which is 191 of them, the surgeries were successfully performed in the morning as desired. And in 4.7% of the shunts, the surgery was done as an emergency. And most children were having their first shunt implanted. And the median duration of surgery was 65 minutes. And the number of persons in theater during the operation was an average of 8.22, with Harare having the highest number of people in theater. 57, which is 71.3% of the shunts, were done by surgeons in their 3rd year of surgical residency training in Harare, while 7 were done by a consultant neurosurgeon. And for the other 2 centers, a consultant surgeon did all the surgeries. Shunt infections were diagnosed in 4 children, giving an infection rate of 1.9%, which is per procedure. The infection rate was noted to be 2.94% in Harare, while it was 2.13% in Oshakati, that's in Namibia, and 0% in Lubumbashi, that's in the DRC. And the median time to develop infection was noted to be 8.5 days from the day of the surgery. And that's a flow diagram just gives us the summary to say 273 patients were it had been evaluated for inclusion into the study, but 209 met the criteria for the study. And the total number of shunt infections was 4, giving us 1.9% shunt infection rate. So the outcome of this study was published in the journal Child's Nervous System, having been accepted on 15 August 2019, and it was published in 2020. So we are presenting this as a possible solution, which can be made use of during shunt surgeries, especially in low resource settings. Thank you for your attention. That's the end of my presentation.
Thank you very much, Professor Musara. Yeah, really an impressive result of your study, and I'm sure there will be ample discussion on this at the end of the first 3 talks. So please stay connected to us. And then I can invite the next speaker, Professor Tito Pereira from Bogota, from Colombia. He will speak on the usefulness of ICP and waveform in the treatment of hydrocephalus. Tito, please, can you share your screen?
Yes, sir.
Enlighten us on this topic. Perfect. Yes.
First of all, good morning and thank you for all of you, and special for Professor El-Ghandour, Professor Luis Borba, to inviting me to share with all of you this concept. Hopefully it will be useful for you. And also, I don't have any disclosure, and I would like to invite in 2 months to go coming to Colombia. We are waiting for all of you. This history of waveform started in 1983 at the University of Minnesota at the Henry Piccone Medical Center, where we was working with the hyperbaric oscillators for trauma with Dr. Geller Rodolph, and he was a teen at that time. And let me tell you the history. Sometimes when we measure with Raymond catheter, we see this curve very flat, and we will think this system like was a hydric system could be no worse. But the issue is when you saw sometimes the waveform, and you move the head of the patient, the pressure going up. Later, after this situation, we begin to see something happen. We are missing something, and we continue to do this research in 1984 in the San Rafael Hospital, where was come to work in my country with this team. I was the chief of that department, but I was the honor to work with Professor Salomon Hakim and all this team of residents, and also the Professor Alejandro Jimenez, who knows very since this pathology hydrocephalus. You can remember Dr. Hakim discovered and used the first programmable valve. And the concept is very simple. Most of you, when you measure ICP in any pathology, only look for quantitative value, could be from 5 to 15. And also, we don't take care about the waveform curve. And we can see in the waveform curve, we have 3 pipes and we think it relates to the, according to the Monroe-Kelly doctrine, the blood, the CSF, and the brain. And you can see this is the original concept. And also we have to take care about the CPP and blood flow in these patients. The first concept of the curve waveform was lumbar in 1986, but 860, excuse me. Lumbar's way, he take the measure of the ICP in trends, in hours, not in instantaneous, to look the waveform, and he described some three curves like they call tape I1 and B and 2. And this was related only with the compliance of the brain. Later, Douglas Miller works very hard in this topic, follow this concept, and he was describing the curve, and he says when the curve is normal, or like you saw here, P1 is higher, P2 in the second, and P3 more down, they say the brain have compliance. And then we introduced, according this concept, a real concept that we are using, that we will see if we have the right explication for these three peaks or not. And we call phase one is when the compliance of the brain don't permit that the intracranial pressure going up, that they can receive volume. Like example, typical example, Cushing from the in the last beginning last century says that the brain, the meningioma is silenced like a wind, and you can see very big tumor in the patient relative was well. But in this phase, in the phase two, you can see with a minimum volume, the intracranial pressure going up. In this concept, we have this normal curve. And but in this time, when the compliance is used in a special P2 or P3, could be normal pressure, but the waveform is not well. This concept was publication for the 90s in our neuroscience in Colombia. So what is in this period, the really compensation? What is the change that the pressure change? And according to this concept, in this curve really is only in that time in the Richmond hydraulic systems was because it's not working well, or it's because we are missing something. So we begin to solve this with other systems that were more precise, and also discover that the ACP can go very high when we have in the phase two. And in this concept, we begin to show what is the morphology, or what is the mean P1, P2, and P3, and we describe it C curves, T1, T3, and T according to the Monroe-Kelly doctrine of a brain, CSF, and blood. And this type 1, you can see the yellow is the brain, is increasing, and the curve is flat because the pressure in the brain is compensation in the first stage, but later with anything could be go up. And the brain, you remember, is what, like sponge. They can have many water because the all neural cells is around of the vessel who made the architecture. And you can see, you see this form. We drop the in the blood pressure. You can see this curve will be changed automatically. That doesn't mean that this peak is related with the blood pressure and the fluid in the vessel of the patient. AB is when the CSF is growing up, when the CSF, even in the ventricles of the other concept, is up, and you can see this type of that we call curve of hydrocephalus. Why? If you say cause effect, we have this curve, you can see here in this scale is for 20 to 25, and you can see it's around 18 or 19 that could be normal pressure. But in this case, if we have reason, if we remove CSF, the curve have to be normal. That you can see here, we take out ACC of CSF and then see 3CCs, and you can see how the curve is changing to the normal, even the pressure is around 13 sometimes. So this is the issue that we can discover that really this curve means, like Monroe Kelly doctor, each element of the CSF. About the circulation, Harvey Cushing, that I mentioned before, was the first time, and we have here in this picture the CSF normal way that we understand it at this moment. But now we have another concept of the physiopathology and the physiology of CSF, and in the future we have to do very research for really know what is going on with the CSF. I mentioned to Mitsuhito Mase from the Nagoya Hospital in Japan, because he's working very hard in this concept. And today we have to do the lymphatic drainage system today, that we can see the, according to many research starting in 2004 and 2010, 2017, 18, 20, that the new concept that the CSF not only goes to in the logical sinus, but also can be in another place like olfactory bulbs, and many concept of the blood barrier could be made. We have to see in the future really how will we work this concept. I see of is when the venous system, special in the blood venous, will be increasing, and in this way we can excuse me, I have problem with this computer. And you see this the curve that peak is going up. So the morphology in our concept is related to this pathology. Type 1 edema, type 2 hydrocephalus, and type 3 hypemia. You can see this is normal waveform curve, and also the value is normal. And we have to think what we can do, what is the treatment for each time, especially I did this reserve be in the beginning for trauma. And we think in edema is for this reason we use many treatments when the ICP value goes up, and we use sometimes pentotal or hypervolemia or mannitol or increase blood pressure or take out CSF. But we have to do according to the problem of the brain. If we use a pentotal, for example, in edema, and the patient don't have hyperemia, the patient will be worse because the blood pressure with this treatment will be up, will be down, and we can give more problems. And we use mannitol with hyperemia. Later, the mannitol will be made problems with the time. And also, if we take out CSF in one patient who doesn't have problem of hydrocephalus, we will have problems. It's for this reason I want to tell you our experience in more than 4,000 monitoring and how will be way for help us. Today we have 3 treatments in neurosurgery for try to treatment this pathology. External ventricular drain, ventriculoperitoneal shunts, and endoscopic ventriculostomy. I want you to review what is our concept of this. You saw here, this patient have problem in the posterior fossa, could be bleed, one tumor or malformation or whatever. And in this case, we don't have cyst, and the subarachnoid space is closed, and severe edema and hydrocephalus. And if you saw the pressure is 25, and the curve is a pale, and we, in this time, we prefer doing shunting, and after shunting, external shunting, you see the normal curve was again. We have to take care of this because sometimes we open the system and going very high, take out the CSF, we can have this compression between posterior fossa and superior supratentorial space, especially in the ventricle, and we can get this if we can damage because the brain state could be have hemorrhage. For ventricular tunes or ventriculoatrial tunes or peritoneal, we have no idea. Close here and space, and we have highly. But one of the theories, and you see the curve and you see the value of ICP, how we make calculation, selection pressure for putting the chin, 15, 12, 14, wherever you want in the program valve. So you saw this curve is abnormal, and we take out CSF until the time the curve was normal. In this time, this is the pressure we have to put in the shunt. And you see, we are starting in 18, and we will be worse in 12. So this is the real concept for relation pressure in our system. Now, what about the endoscopic ventriculostomy? The patient don't have to have edema, and also the adequate subarachnoid space, and also open system, especially the pointing system. In conclusion, the use of rationality of treatment and selecting the procedure in a hydrocephalus, we are using the morphology curve and have as to prevent second damage in this patient. In the last, I will invite all for the World Congress of Neurosurgery that will be in present, no virtual, in Colombia, in Bogotá 22. We have ready the program, and also until this moment, we are receiving, and thank you all of you, more than 1,000 papers, 700 for presentation, and 400, almost 500 for poster. We are working with the open hearts here in Colombia. Thank you.
Thank you very much, Professor Perea. Well, Tito, I just can say this is, I liked it very much because you bring something into memory of neurosurgeons again, which is the waveform. And not many people, they often are focusing just on the number of the pressure, so this figure, but it is about waveform. And just to remind you on history, it didn't start in 1983. We should not forget Niels Lundberg from Sweden, who started this already in the early 60s. We named the waves, actually, some waves, the plateau waves, A waves, B waves, after him. And don't forget the work of Langfit and Marmoreau already in the 70s. And based on that, of course, Cardoso in 1983 and all the others working this, and what you did, it's fantastic also to bring this into the treatment of hydrocephalus. Very important to think, and I always teach my residents, please look at the change of the P2, because that's a very decisive step, because P1 is arterial, P3 is the closure of the aortic valve, and everything that changes in the brain usually reflects in the P2. But I know there will be a lot of discussion. I look forward to it, and I see already some questions in the Q&A, so we will come to that. But I move on and invite Professor Nelchi Sanon for her talk on the treatment options of neonatal hydrocephalus. Please.
Thank you.
Good morning. Thank you very much for this kind invitation, and congratulations, Nasser and Borba, for this wonderful seminar. Talking about neonatal hydrocephalus, and just tell that I'm working in São Paulo, Brazil, and some words about etiology and diagnosis before going straight away in treatment options. The treatments of hydrocephalus remains one of the most difficult, challenging for the neurosurgeons, not for the technical issue, but for the decision-making process to choose the best method for each patient and what is the best moment to do this kind of surgical procedure. The prevalence, just to have an idea, the Latin America study shows that if we have hydrocephalus and spina bifida, we almost have the same number that Down syndrome for this group of patients. How we can see the clinical signs of this neonatal period is bulging fontanelle, open suture, bradycardia, and seizure. But in neonate, we can see the decrease of hemoglobin and showing that there is maybe intraventricular hemorrhage like the first sign. Before treatment, how we can do to see what kind of CSF we have, if it's post-infectious or hemorrhage or only aqueductal stenosis. The better way is to do a ventricular tap, no more than 3 times, to avoid porencephalic cyst on the frontal lobe. And there is medical treatment to treat these hydrocephalus patients. They are small, usually intubate with an immature immunological system, skin problems. No medical treatment for these patients. Acetazolamide is not indicated. There is higher mortality and no recommendation at all, class 1 evidence. The etiology for this particular group of the patients, basically, we have 4 etiologies: spina bifida, intraventricular hemorrhage, congenital with or without antenatal diagnosis, and infection. The post-hemorrhagic infection is the most common cause of acquired hydrocephalus in higher income countries, and is responsible for over half of these deaths in infants before 32 weeks of gestation. The prematurity is by itself a problem and a pathology. In low and middle income country, the most common cause of hydrocephalus in neonatal period is post-infections and myelomeningocele. How we can choose our best tool to do this image? The first indication is ultrasound. It's easy to do and not need to transfer the patients to the radiology like we need to do CT scan or MRI. The CT scan is radiation for this patient is not good, and MRI there is the cost and availability is not to everyone available. When we talk about ultrasound for these patients, it's interesting to keep in touch with our radiologist, not only to have the diagnosis about the ventricular index and ventricular dilatation, but what kind of classification, the grade, the papillae grade. Why is it so important? Because if we have grade 3 and grade 4, we know that we have high risk mortality, bigger ventricular size, and also if he is grade 4, we have 90% of neurological deficit. It's important to talk about the neonatologist and with the family about the prognostic factors. What kind of ventricular index we can use? Doesn't matter. The most important is the neurosurgeon, the pediatrician, and the radiologist are easygoing with the ventricular index. The Evans is one of options, but not necessarily. And the guidelines to do the surgical treatment for these patients, it's a progressive ventriculomegaly. If we can, it's important to do serial ultrasound once a week or twice a week. Ventriculomegaly more than 97% percentile, and other details if we need, if it's multiloculate or isolate hydrocephalus, the MRI can be useful to us also. The curve is very important to see, not only the head circumference, but what means for these patients during these days. And we have several options to treat these patients: lumbar puncture, a reservoir or access device, subgaleal shunt, external ventricular drainage, endoscopic, third ventriculostomy, and or ventricular lavage. The serial lumbar puncture and ventricular reservoir, we have a systematic review from 2017 that there is no evidence that repeat removal CSF by lumbar or ventricular reservoir don't bring benefit for disability, death, or need of ventricular shunt, permanent ventricular shunt. Ventricular subgaleal shunt is level 2 evidence and can reduce the daily CSF aspiration, and it's a moderate recommendation for clinical certainty is level 2 evidence. There is the last year this paper from Calcutta, Professor Chatterjee group, that's showing that we can have decrease of the shunt-free patients, or it means we need less VP shunt when we use ventricular subgaleal for this group of patients. We have a prospective comparative group comparing ventricular reservoir versus subgaleal, and for this group of patients, it was no difference in the proportion of the patients that need a shunt after this transitory period of treatment. The question is, maybe is a special group of patients, or we need more number of patients to know. The external ventricular drainage can be reliable. We need to pay attention for infection rate, but we can reduce the risk of shunt infection and severe disability. We have level 3 of evidence on external ventricular drainage. It doesn't matter what kind of treatment we do for this patient. It's very important to pay attention on follow-up, strict follow-up. Just an example, the patient was discharged with 2 months without VP shunt, and 3 months after came with this increase of clean signs, and maybe if we got in touch with more closely follow-up, we can treat these patients early on. After VP shunt, we have the clinical improvement, but probably not gain on cortex and cortex mantle on this special patient. What about endoscopic third ventriculostomy to treat this neonatal hydrocephalus? Evidence level 3, there is not recommendation to treat post-hemorrhagic or post-infection hydrocephalus on this group of patients with endoscopic third ventriculostomy. And this ATV success score, it's shown by Professor Kulkarni from Canada, that if we have infections and less than 1 month, we have the very, very low probability to have success on this treatment. But talking about neuroendoscopy, we have other possibility. We can do ATV plus CPC and also ventricular lavage. And if we have fenestration or multi-septate hydrocephalus, we can use endoscopic procedure to bring in only 1 or 2 cavities. There is 2 interesting papers in ventricular lavage from Germany. Tomali shows that the neuroendoscopic lavage can decrease the number of shunt revision and shunt-dependent patients after this treatment. And also, it's important to see that in some patients, it's necessary more than 1, 2, 3, or 4 endoscopic lavage to treat intraventricular hemorrhage. Just one clinical case from the university the last year. It was a routine case. Myelomeningocele patient treated with a VP shunt came back for months with tense fontanelle, irritability, and abdominal distension. and no signs of problems in the abdomen, but it was a clinical important pain and discomfort. We decided to do a ventricular tap. It was CSF normal, but after externalization, it was shows that it was worsening CSF and no good anatomy to do ATV. And after we confirmed that it was ventriculitis, treated with external ventricular drainage. The question came after 7 days. It wasn't enough the treatment because we don't have a CSF quality to put a VP shunt. And at this moment, we decide not only change the AVD, but add a ventricular lavage. We can see here, we just go inside the ventricle with the endoscope. At the beginning, we saw very blurry CSF and a lot of cotton-like inside the lateral ventricle. Usually, we see this kind of infection when we have fungal infection. It was the case also. We saw the catheter inside the ventricle before changement. And one thing we learned with this particular patient, at the beginning, the suction was with a syringe, but it was so slowly that we need to spend much time on this small baby. And when we change to just connect with the suctor, it was quick, and we can clean this CSF with more velocity and taking care for the structure behind. We saw at the end less complicated ependema, even if we saw a very thin ependema, but it's better than it was at the beginning of the surgical procedure. The choroidal plexus is there, but it doesn't coagulate. It doesn't use flexible endoscope, only rigid endoscope. And we replace at the end with another ventricular drainage, external ventricular drainage, just at the end of the treatment. And it was guided by endoscopic to put the new catheter inside this ventricle. And this child, it was well solved the problem. It was, this suture was solved, and apparently no need of additional shunt, we just removal, but few days after came back with enlarged ventricular and bulging scar, and we put VP shunt, and we finished this treatment after 67 days. It was difficult. And just to remind us that time to time, we need to switch one treatment to another. When we call definitive treatment is not necessary for this particular patient. And when it's time to put a VP shunt after temporary treatment, there is a level 3 recommendation to wait for 1.5 kilograms, but we don't have the precise amount of protein cells or glucose to be sure that we don't have reinfection. Just in summary, intraventricular thrombolytic agent and acetazolamide is not recommended. Level 2 ventricular access device and ventricular subgaleal shunt are in place. And we can reduce mortality and morbidity when we use reservoir when compared with extraventricular drainage. And ventricular lavage, we are waiting for more data. There is a prospective study running right now. Our policy is first we treat with AVD. If need AVD replacement, we had a ventricular lavage. And first VP shunt, we wait until 1 kilogram or 1.5 kilogram. Just the message guideline is important, but individualized treatment can help, and try to build a database to compare patients with the future is important. And endoscopic treatment can be a tool to help this kind of patients. Thanks a lot for listening.
Thank you very much, Nolshi, for this overview of a still very challenging group of patients that we have to deal with. I mean, you call it's neonatal hydrocephalus, but we all realize that these are very often premature neonates. So it's a very, very difficult group, and we have to individualize, but realize also the possibilities we have. And with the endoscope, you nicely showed it, we have increased the possibilities of adding something like the controlled lavage, controlled placement of shunts, etc. So this is really something that is still in very, very difficult issue for most of us who deal with these patients. So thank you very much. And well, we will now open the discussion for all the three papers. And the first one was from Professor Musara. Is he still around? I don't see him here in the gallery. That was, yeah, Professor Musara, you're still there. There are some questions. One remark for myself is, I mean, this is an amazing figure, having 1.4% of shunt infections. That is, it's close to the dream of 0%, as Professor Kasari Kalangu was mentioning in his article. From the literature, it is known that it's not the typical protocol that you're using, but simply the fact that you have a protocol and that are people adhering to a protocol is already lowering the rate of infections. That's very important. I was surprised that with all this is you show, do it in the morning and not after another infectious surgery. We also added no door movement. Simply in the OR door, when there is a shunt, there is a big board hanging outside, do not enter shunt. Yeah, and then that means no unnecessary movements of people around. And you had more than eight people being in the OR. We restricted to the surgeon, the nurse, and the anesthesiologist. And try to do it as the first. And the youngest, the first, and then the older, the second, and so on, but not as the last surgery of the day. So there are many protocols, and I really, really appreciated your effort and the results that you did. When I now look to the question and answers, the Q&A, there was a question. There was a question on how different were the setup in the three hospitals that were involved. That was so Harare, Anoshakati, and Lubumbashi. Was there a strong difference in setup, or were they very comparable in how they were dealing, despite the fact that in the other two consultants were doing the surgeries, in your hospital also the elderly residents were doing it?
The difference, maybe you're looking at the number of people who are in theater. In Harare, you tend to have more people in theater, especially because of so many medical student trainees who are supposed to get their exposure. And as you can take note, this is an operation which we often give it more to the residents as well. So you get the junior residents who are being there as well to learn at the same time, while the operation is being shown to a slightly more senior resident. So the difference is mainly about the number of people in theater. The kind of setup is more or less the same.
More or less the same. I think that's also wise to do if you have a multi-center study. But that's and conducting this, just I can only say congratulations. And wonderful endeavor to do this. And you see that it gives a result that is just amazing. There was another by Raimundo Ortiz, but maybe if he still is around, he can raise his hands, because I'm not fully understand the question that he was raising. It's partly in Spanish and partly in English, and so if Raimundo Ortiz is still there, it's something like handling the shunt by hands, but I'm not sure about that question anymore. Any other people now around? Let's see. And no, not yet. So we go to the second with.
May I say something?
Yes,
Professor?
yes. Please, Luis, go ahead.
Yes. First, I think you need to recognize the work of Professor Maurice Schulz in Morocco during many, many years.
Oh, how they
in the Air Force to change the way to treat hydrocephalus. I remember when I was the first year resident, junior resident, Professor Maurice Schulz came to Brazil, and when I went there to see the big professor give a lecture about medulloblastomas, big tumor. In his first lecture was about shunt, how to prevent infection, how to work the infection. And this really changed the work, how to treat this pathology.
No, Luis, I agree with you, because this is in my generation, so from the end of the 70s and early 80s, shunts were considered by consultants as a surgery doing by the youngest resident.
Yeah.
They were not taken seriously. We now realize that, especially for the neonatal shunts that we come on, the shunts is a serious thing, because you can do so much wrong, and it has to be taken. And that was the work of Di Rocco and Shu, absolutely, realizing that you only can improve the fate of these children when you take this surgery also seriously in any respect, in placement of the ventricular catheter, in reducing the infection rate, in reducing the rate of revision overall and dysfunction. We will listen to the talk by Professor Boop later on, because shunt malfunction is still there, and shunts are around. I mean, when endoscopy came in, we have changed that, but of course, it's only a minority of patients that can be helped with ATV. So shunts are still there. And it's so good to know that this is real neurosurgery. This is an important part of neurosurgery, and you can gain a lot for your patients when you do this properly. Absolutely.
May I make a very short question to Aaron. Congratulations for an excellent presentation, but very basic question for me as a junior resident, okay? When you decide to put frontal borehole or parietal borehole, at your parameter to use the frontal or the parietal?
We make use of the parietal borehole.
You never use frontal?
We rarely do.
Yeah. Well, I understand the question, because there was always the discussion. Doing it here, it's a shorter way going down with the shunt, but doing it here frontally, you have less plexus that can obstruct the ventricular catheter. So there is always, so it's that's still an open discussion, but I know that. But the way is longer, which is in the youngest of children not such an issue. But in elderly patients, they prefer actually having it here, because here, as you see also, my hair is gone here. It would be visible, visible as a bump. But I mean, these are minor issues. Nelchi, you also have a question. I see you raised your hand.
Yeah, just one word about frontal and parietal access. We don't have evidence to prove that one is better than another access. Right. For the frontal, we need a contra incision, is the question we try to keep on the occipital. Some papers try to prove that frontal there is less blockage, but maybe we don't have enough numbers to prove until now.
I think so. Tito, what is your opinion?
But if we put in the parietal, the tip has to be in the frontal horn, yeah, to avoid the choroid plexus, yeah.
No,
Yes, yes.
no, that is the occipital. That is the occipital. Occipital you can place. If you have the temporal parietal, you never get it into the, it's in the atrium. So you never get it really into the frontal horn. That's hardly possible. So you have this 5 centimeter, it's sticking there, and there is a lot more plexus. The occipital, the really occipital, and the 3 centimeters, you can fully, therefore, actually, the manufacturer has constructed this 15 centimeter of ventricular catheter. Why would they do that? Because you can reach the ventricular system from any place in the skull within 5 centimeters. So why do they offer this long ventricular catheter? It's from occipital, you need 9 centimeters to go inside. That's the only reason we have that. So the really parietal, just above the ear, you never really enter in the front. If you try to do that, especially with the trocar end, you end contralaterally. So don't do that. Okay, then well, listen, we can discuss this.
You'll be clever here.
I'm absolutely sure, because there are many opinions. But Tito, you raised your hand. You have a comment to this. You are muted, Tito. Tito, unmute yourself, please. We don't hear you. Yes.
Excuse me. 2 things. Professor Musana, my congratulations, because you remark 2 points, that this operation have to be perfect. It's no single and easy operation for do very well. You have to take care many details like you show. This is the first issue. Second, according to this, the question of Dr. Borba, I am saying you have to select exactly the patients, because you are discussing where you put in the borehole, front or occipital, no parietal. Never we use parietal. We use occipital, but the issue is we use
Greetings from Paraguay.
frontal.
This is Dr. Ortiz Portillo from Ciudad del Este.
That we use frontal is because you want to have near the catheter of the Monroe, because in that way you can handle the 2 ventricles. And from the occipital, depends on the case, sometimes is more difficult. This is my clear and right opinion.
Okay. Well, thank you for this addition to that. And we come now actually, please stay online, because we come to questions on your lecture, because one question is, do patients have to go to the ICU when you do these pressure measurements?
No, not always. You can use the picture that I showed you was in the room with external ventricle in the operating suite, wherever, because today we have any kind. In the operating suite, you have monitor, like for blood pressure, you can use for measure ICP. So today is more easy to do it and cheaper do it, because it is the same cost that putting one ICP that putting one blood pressure measure. It's the same thing, so it's no problem.
It is not always necessary, and that's
no,
because this would restrict, of course, the application of such a measurement. And also to you, it is this by Enrique Okola, who congratulates you for the interesting lecture. His question is, how is the morphology curve pressure, and what can we do in cases of intracranial hypotension after hydrocephalus, after VP shunt? So if there is hypotension.
Yes, I show you, this is a very interesting question, because when you going drop the ICP quantity value like 5, that could be possible, you get problem with Dr. Nancy show, like hygromas, or infusion, many problems after that. We have to take care of that. We never think that, but it's true. The curve will be flat, very flat. And this is extremely care because in this time that the slide that didn't have enough time for going on details, you can get problems because the pressure from the posterior fossa, because you are no drainage, the four ventricle, if you have obstruction, could be for meningitis or whatever, you can get the compensation between supratentorial and infratentorial space, and all arteries will be trying to go up to the supratentorial territory, and it will be got like trauma, direct hemorrhage. And be careful because some of these patients after that will be get more problems than before. So
and
you
it's not
have
only
to compensate. If you do one procedure that very useful that Dr. Nancy showed us for very difficult pathologies, when you have infection or membranes or whatever, you try to put in saline into the ventricles for compensation and don't permit this discompensation. We must do it. Many people live like that and put in plus one shunting, and the patient will be, maybe we cannot see because there are little childs and we not very attending to many function on the brain stem. This is my concept, and be careful if you saw the pressure is growing down, and also the curve is flat. This is our experience.
So you have done also these measurements after shunting.
Yes, because we put in, if we put in a sternal dress, we connect it to see, and we cannot permit the adrenal external shunting go below of the value of the morphology was well, that is around, in the minor cases, is around 7 to 10 in our experience to measure of the, if you go little by 5 of the intracranial pressure quantity, even you have one normal, the curve will be flat, and because the tension in the sural space is nothing. It's for the reason you get infusion.
Okay. Let's see. Let's move on, because also because of the time, there are more questions on this, because I think this is a not so well known and understood situation for many neurosurgeons. A question for Professor Zanon on the ventricular lavage. Do you do it with what kind of solution?
Thanks for the question. Usually a ringer, if we don't have artificial CSF, or physiological serum normally. And just warm, not nothing different or special.
But body temperature, it is very important.
Yeah. Yes, absolutely right.
It takes some time, and it is incredible how the amount of fluid you actually need to do this. When I first realized that, I was shocked myself that I was rinsing this through the small brain of a neonate, the amount of fluid. But keep it warm, and if you stand it on the foot end of your OR, it can already cool off before it enters the ventricle. Please be aware of that.
It's important to talk with the anesthesiologist, because you can have some troubles, bradycardia, tachycardia. You need to stop, wait, be sure that everything is okay with the neonate, and to continue after.
Absolutely right. Yes, very. turn on the noise of the monitor, so you hear also yourself beeping. Actually,
Yes.
the tachycardia starts first, and then it is bradycardia and asystole if you don't be careful. So
Absolutely.
it's very important. There is another question: how do you choose the shunt pressure for patients?
Usually,
more all of you.
yes, we use a normally fixed pressure. Usually we start with medium pressure for the majority of the patients. The question is try to find a neonatal size, because it's a small baby with trouble on the skin. If you don't have neonatal profile of the shunt, you can get in trouble only for the size of the valve.
Yeah, the skin will break down. The skin
yes.
breaks down. Yes, very easy.
The first 10 years, we usually put low pressure valve. And when they growing up with several difficulties with slit ventricles or difficult to manage intracranial hypertension with a small ventricle, we prefer to start always medium pressure.
Yes, somewhat larger ventricles is not so bad, as long as the subarachnoid space is still visible and open. That's fine. We have to move on the time.
May I just ask one question?
Yes, the last question is to Moody, but then we stop, and I would ask all the speakers to go to the Q&A and answer the questions related to their talks in that Q&A section. Moody, you
thank you very much. I mean, it's always a very fascinating discussion when it comes to hydrocephalus. Considering that perhaps 60 to 70% of the audience are going to be from LMIC countries, and by and large, particularly in our setting, we use the low-cost Chabra shunt. And I know that in many of our centers in the West, we use the Codman and the other more expensive shunts. In our country, the Codman shunt, for example, will cost somewhere upwards of $250 plus, if not more. And the Chabra shunt costs $35. Ben Wolf did a study in Uganda which compared different shunts with the Chabra shunt, the other more expensive shunts, the programmable shunts. I don't think he used the programmable, but the more expensive shunts, and found that there was no difference. I just wonder, and perhaps more for the reassurance of those of the audience that practice in LMIC countries and perhaps use the low-cost shunts. I know that Aaron in Zimbabwe has the Harare shunt, which is basically self-designed.
Yes,
and the results are very similar. I'd like someone to comment, at least give a fair and firm guidance for those who use those low-cost shunts, not to worry that they are perhaps not giving their patient the best treatment. Any comments on that for those who use?
Maybe that is for Professor Musara as first.
Musara uses the low-cost shunt. I would be more interested to hear from those who use the more expensive shunts, whether they really feel there is a big difference, and that's why they use the more expensive shunts.
There is no much difference. We use the Brazilian shunt, for example, and we use also the other the foreign countries' shunts. We don't perceive real difference on the result. Don't be afraid. The most important is not the cost of the shunt. The most important, I think, it's the care you have. You need to take care for these patients, and you are the master. If you are prepared and if you have a catheter at least, I think you need to do it and do your best.
I think that's reassuring, and I think it'll be absolutely to many participants who use those low-cost shunts most regularly. Thank you.
I see Professor Ertel has arrived, and he also raised hands for a question. Joachim?
No, I just want to comment on the Moody's question. I have a limited experience with the Chabra shunt since we did now like 4 or 5 missions in Africa. And we routinely use the Mietke programmable valves even in the neonates. So from my perspective, probably the vast majority of patients is treated very well with a very simple shunt. And there's a small subgroup which you have to deal with problems. And in these, it might be helpful if you have a programmable shunt. But it's not compared to all the disasters you have with the shunt in the neonates and small babies and infants. I mean, then probably 95% of the patients are treated extremely well with just a very simple system. So I think there's no reason to really proceed now and put in like for 3,000 euros or something implants.
No,
So,
no, I think this is a wise command. To see also that for example, you now have shunts that integrate a telemetric device in it. And I think this is more for the neurosurgeon to play with than it really adds anything to the treatment, long-term treatment of patients with hydrocephalus until now.
Professor, may I leave one question on the air, just to think. The problem is the shunt or infection or misplace of the shunt, more than real material.
Yes, no, listen, those two are the most frequent problems. It's misplaced shunts and it's infections. Yes. But of course, the hardware is also an issue. But it's not the most important issue. I fully agree with you. These two others, and therefore Professor Musara was showing this, infection you can deal with that if you adhere to a protocol. It's reducing, and the same is, of course, the disease itself we have to understand better and treat from an early phase on. The etiology is something we can't influence, and so this is part one. I said, I'm sorry, Tito, I said Moody's question is the last. We have to move on. Please, this discussion we will, I have to move now and give.
I only want to say some words about Professor Moody's questions.
Oh, okay.
Because there are difference between my experience with all these system measures, the ICP monitors, in the little charts that Nelson shows, even in sometimes in Colombia we use without only tube, without system. But because in that patient, you want permit with only one system in individual system, you can use a full because the hypertension and the intracranial pressure is very low. But when the child is growing up and in adult patients, we prefer using we use a Hakim system programmable valve because in these patients, if you draw only 10 centimeters for example, to 16 to 14 pressure, you can get problems. And you can see the patient is more with more problems of conscience, at least for 1 week or 2 weeks. And this is the reason we think is more important. Give very quality of care of the patient and save. We cannot permit, and we try to be like cardiovascular surgeons. We have to improve the technology in our field for they give more safe to the patient. Even if the cost could be whatever, but we have to try to get that. I know we are working in one country in Latin America with very poor patients. It's for this reason I tell you this, but we have to think in that way. We have to give the best quality and best treatment and the best technology that the patient needs.
Yes, but Tito, this is a different discussion. I think that everyone wants to deliver
I know.
the best possible.
Excuse me.
Yes, no, this is the best possible treatment that is available in a certain situation, but we have to stop it just because of time. Otherwise, I think these three lectures could have give a discussion that would last until long in the evening and late afternoon for you and your place, but we can't. I hand over the moderation to Professor Urtel, so that we can proceed with the program. We have still some very, very interesting talks ahead of us for this now already wonderful webinar. Please, Joachim, take over.
It's really one of the best discussions I've had recently on the online. Thank you, Andre, for taking over for me. And now we've switched, so I take over for the second session, and this is the Russian-Indian session. I saw already Albert. Albert is the first speaker. He's from Tumen, and he will speak on endoscopic management of slit ventricles. Albert, is all yours. Albert, where are you?
Yeah. I'm here. Yeah, sorry. Joachim, thank you very much for introducing me, and thank you very much for Professor Nasser and Professor Luis Borba for inviting me for this very important event for neurosurgeons around the world. So thank you very much. And now I want to speak about the problem. Yeah, okay, it's possible to see. I want to say about the surgical management of the slit ventricle syndrome. Again, some words about. I am from Tumen. This is very beautiful city, just midline of the Russia, just in West Siberia. In our center, just now created in the Tumen city. Introduction of this problem. The problem is the common features you know very well. The slit ventricle syndrome is a chronic complication of the ventricular peritoneal shunting placement for the treatment of hydrocephalus. It is not so rare. It's observed sometimes in between 40% of the patients who undergo shunt procedure. So this is a common situation, and most of the surgeons who treat the hydrocephalus just meet with this problem. And sometimes this problem is very difficult to have a good decision how to treatment. So like the clinical trials is the standard, the features of the headache, nausea and vomiting, slow refilling of the valve, and narrow ventricles on the imaging. You see, like in this CT image. A lot of theory we have now about pathophysiology of this pathologic condition. You see on the slide, and don't explain all of this. We know about, but we know about this pathophysiology because sometimes it's necessary just to have good decision for the treatment. And also we use classification of shunt-related headaches by Ricotta in our clinic. You see in the slide, you see the step of this classification. I also not pay attention because I think limited in time. And some pathophysiology possible to see in this slide about how this condition develop. Most important things is about excessive drainage of the CSF through the shunt system. So it causes the intraventricular or intracranial hypertension and collapse of the ventricles, and after collapse of the ventricles, the proximal ventricular cutter must possible to occlude it, possible occlusion. So After occlusion, again, CSF collected and this expands the ventricles, again increase the intraventricular pressure, and again after this shunt reopening. And now after this circle is repeat and repeat. So this is some very common knowledge about this pathophysiology, and give us possibility how to treat. Another very important and very famous guy is Panagopoulos. He also created for us some knowledge about this pathophysiology. Also, I show in this slide. So how to treat? So lot of options we have now. For example, most common is if the headache is due to intracranial hypertension or over drainage shunt system, some add anti-siphon device or upgrade with existing anti-siphon device. And another most common options in this situation is increasing the valve pre-opening pressure. So it needs the replace of the existing non-programmable valve or upgrade. Also, if ventricular catheter during the collapse of the ventricle is have obstruction, for neurosurgery, very important to check ventricular catheter and replace in case of obstruction. In some very difficult, complicated cases, we need some combine of all these measurements. This is a typical standard algorithm for the treatment of this difficult situation. Можно брать эти вещи? Okay. Okay. We have, of course. Oh, sorry. Of course, our center we have a pediatric department, and we have more than 600-800 surgeries per year. So more than 100-200 shunts every year. So during these 10 years, we have a lot of shunt surgeries, and of course we have now sometimes problem, and we have experience with this slit ventricle syndrome treatment. And so this knowledge gives us possibility to create our algorithm, our surgical treatment measures in shunt over drainage by our experience, because we don't use only standard common procedure, neurosurgical procedure, because we use some endoscopic possibility introduced in this algorithm of the treatment inside of this very difficult group of the patient. And you see on this slide is the decisions tree is not easy. So why I little bit explain about our decision tree. If patient have some slit ventricle syndrome, as I described before, for example, first step is very simple. It's a standard simple. We try to increase the valve open pressure. We replace to the programmable valve, for example, or upgrade, or sometimes we use replace of the ventricular catheter if ventricular catheter is obstructed. But we have some lot of endoscopic experience, why we commonly create a replacement or a revision of the ventricular catheter by endoscopic technique. So this is the first step. But after this situation, the causes of the slit ventricle syndrome, it will be divided on the two groups. First group, and this is the most common group, this is an uncomplicated course of this treatment, uncomplicated test. So it's enough these neurosurgical procedures is enough just for relief the pathological condition. And in more than 80% of the cases, the symptoms resolved. And we have the group of these patients, like more than 100 patients like this. So we just only increase the valve opening pressure, and more than 100 patients is enough. So after this situation, we step by step increase the pressure on the valve. So we enlarge the ventricle, step by step, very carefully. And when we have the clinical assessment of the patient condition, if patient conditions good during all our duration for the patient, we remove the. It's possible to remove the shunt, and the patient possible to become a shunt independent condition. It's very important, very important. But this way is a long way. Sometimes it's very easy, but sometimes indeed years of the clinical assessment of patient condition. But result might be is very exciting. Shunt independent conditions, very good situation. But some patients still remain shunt dependent. So not all patients shunt independent, only a selected group. Another course of his treatment is complicated courses of the treatment. So this standard neurosurgical procedure don't give for our good result, for example. So complicated courses. In this situation, we have more than 30 cases now about experience about this situation. If complicated courses is so no resolve the clinical situation, so we see the main step is the check of the ventricular size. If ventricular size enlarged enough just for some manipulation inside of the ventricle, for example, some manipulation for the endoscopic manipulation inside the ventricles. So we provide a standard ETV by, if the size is enough, standard ETV by the standard endoscopic endoscope, for example, like LOTA and so on, because if ventricles enlarged enough, the size of the endoscope doesn't matter. Standard endoscope is enough, and we make the ETV, and after ETV we close the shunt, and then again check. If normal ICP, after closes the shunt system, we remove the shunt, and then only follow up. If ICP is not normal, is increased, so it's another very interesting situation. For example, if ICP increased and now no obstruction, so it's possible to put another kind of shunt, lumbar peritoneal shunt, because it's for patients, lumbar peritoneal is more easy, more safe procedure than ventricular peritoneal shunt. So why first step we create the some cisterna peritoneal shunt we introduce. In this classification, I write the LPC is the caudal cister peritoneal shunt, and also again check if after LPC it's a normal situation. Again, step by step we see. If after clinical assessment the patient condition is good, we long observation, so it's possible also remove the shunt and patient also become independent. But if sometimes it's not enough, or maybe some lumbar peritoneal shunt also have a difficult complication. For example, deterioration by the Chiari malformation. For example, it's possible so chiari malformation very severe. So why we introduce a new type of operation. We create for this patient a cranial cisterna perinatal shunt. What means we put a stent, ventricular catheter or stent, we put not in a lumbar sac, we put a catheter in the interpeduncular cistern or prepontine cistern through the stoma. And then step by step assessment in if a situation is normalized, resorption of the is recovered in the patient, we also remove the shunt. Another situation, also very interesting and not so easy to manipulate, is if ventricle not enlarged with enough size for the standard endoscopic manipulation. So what to do in this situation? So in this situation, we use some measurement and we use shuntoscope because shuntoscope is very small in the size, very small, and it's possible to make some manipulation in even in very narrow ventricles. So why? Next, if we decide to use small endoscope, shunt scope, next stage is we disconnect the ventricular catheter, measurement of the intraventricular pressure, and then very slowly, we artificially expand the ventricles by injection ring solution. By measurement by ICP during this procedure. If we have ventricle enough, even narrow, but enough to put endoscope, we put endoscope inside of the ventricle and then make NTV. The way how we create this is also very different. It depends from the experience, from the some devices what you have, and traditional way for the standard neurosurgery. So for the standard neurosurgeons is to put shunt scope to the narrow ventricle by MR neuronavigation. But and the shuntoscope give possibility for the because the sheet of the shunt scope possible to navigate. Possible to put. Okay, sheet is possible to navigate. Yeah, but the navigation system is not good because we know a lot of examples of the sheet syndrome. So it's we very rare use this way. So most important for us ways is two ways. First one is to introduce the shunt scope in the narrow ventricle by ultrasound navigation, ultrasound control. So it's one of the way. Another way now is more useful, most common in our clinic is put shunt scope in the narrow ventricle through the old canal after the ventricular catheter, ventricular catheter. And after you put shunt scope inside of the ventricles, we create ATV. And then standard way, we create ATV, and then we estimate the clinical patient condition, and if resorption is enough, or maybe restore of the resorption during the time, we also possible to remove the shunt. So this is our surgical trees. just how we treat this split ventricle syndrome. And also, I want to show some of the clinical cases about according by these surgical trees. This is our experience about the complicated treatment of the split ventricle syndrome, complicated causes of the split ventricle syndrome, and we have experienced more than 30 cases about ETV and shunt removement. So 27 child was shunt independent. You see. Etiology of hydrocephalus is the standard, like perinatal damage, aqueductal stenosis, dendiochir, myelomeningocele, carry, and so on. Of course, for this kind of surgery, endoscopic surgery, you must orient it much better than in standard ETV procedure. So why we study very precisely anatomy of the interpedicular cisterns, for example, and you must estimate very precisely the neuroimaging anatomy also. What is the size of the ventricle, unilateral, not unilateral, for example, not necessary to create some, for example, septostomy, not septostomy, so a lot of things you must estimate. And again, very important to estimate and have knowledge about the anatomical landmarks inside, because again, ETV in normal standard situation, normal standard obstructive hydrocephalus, and ETV in split ventricle syndrome, it's too big difference. It's too big difference. Of course, you must need very good devices for this kind of surgery. We mainly use car stores. So equipment must be high level. And main important for this kind of surgery, for my opinion, is to use this needle semi-rigid neuroendoscope. You see the compare. This mini endoscope have lot of achievement for this kind of surgery. So working canal we have, so we possible to manipulate by all instruments like standard endoscopic device, and even mini LOTA, much bigger. Sometimes it's very useful, for example, also, and we use videoscope in this kind of situation. This is new videoscope, and the resolution and light is high level. Compare with the rigid endoscope. Also balance like this, and you see this needle. Small endoscope on the picture. You see all kinds of instruments possible to use through the working canal, like in standard endoscope. And this is standard operation room, And sometimes, in very rare cases, if you lost orientation, it's possible because not so many good landmarks inside of the ventricles after meningitis, for example, cyst, and so on. We also use the intraoperative CT possibilities. You see behind of me. Another very important possibility for this kind of endoscopy is there is possible to intraoperatively use ultrasound control. You see the endoscope with sheet, and this is ultrasound, and ultrasound check the trajectory of the shunt during the operation. during the live surgery. Now I want to show the experience about the uncomplicated causes of the surgical treatment, uncomplicated. So we open the valve opening pressure, replace the valve, and replace the ventricular catheter. You see the yellow, this is our case like this, the way, like this. Case 1, the split ventricle syndrome, typical. And first one, we replace the endoscopic ventricular catheter and the valve. Oh, sorry. Oh, не воспроизводится. Oh, sorry. Уже показалось. Sorry, it's technical problem, but believe me, so by endoscope, it's very easy. We put endoscope inside of with the lumen of the ventricular catheter and check the correct precious vessels, put inside the electrode, coagulate, and then remove very easy and very safely ventricular catheter, and then again put the new one by principle of the endoscope still at the ventricular catheter inside of the ventricle, and then increase the open valve pressure and increase the ventricular size. You see on this slide. So very good result. Another case is a complicated case I want to show you, and you see also a yellow way how we treat this patient. This is a typical split ventricle syndrome, boy, 10 years, and a lot of multiple surgeries for ventricular shunt dysfunction before admission to our clinic. The second stage is we replace the valve and try to open the enlarged ventricles. So in this case, for example, 3 days we create this way. So 1 day 200, not enough for standard ETV, and 3 days we 300 level, and then this is enough size, so we go to the standard ETV. And you see, we enlarge enough space, and we use a lot of endoscope in this situation. We go inside the third ventricle, you see the mammillary body, create the stoma by the deck forceps, then enlarge the stoma by the Fogarty catheter. And go inside, not so deep, but enough in this situation because we enlarge the third ventricle, and we see no problem inside of the interpendicular system. The stoma work very well. You see and after assessment of clinical conditions of the patient, some months, we remove the shunt, and now this patient was shunt independent, and you see the good flow voice, stoma worked very well. Another case, this is also complicated cases. It's very difficult cases for us. Ventricles not enlarged. So case report. You see this video. So also very difficult. Lot of surgery before. Typical anamnesis. And he underwent a lot of shunting operations before. And he come with us with this typical situation. So we plan remove the shunt system from the left frontal horn, ETV, septostomy, ligation system, demontage of the ventricular system at first, ventricular catheter revision. You see the ventricular catheter blocked by ependyma or choleplexus. When we calculate and separate the ventricular catheter, when we enlarge the ventricular system by the ringer, by measurement of ventricular pressure. Oh, sorry. Under the measurement of the ventricular pressure. And when we remove the ventricular catheter and put endoscope through the removed ventricular catheter canal. Now we inside of the lateral ventricle. You see how is the narrow of the ventricles. The main landmark you see inside. This is the tip of Biffre's catheter occlusion site. And you see the very narrow Monroe. And we go inside of the third ventricle. You see how narrow the third ventricle. It's really narrow. But we have and see the main landmark, like a mammillary body. And now we see the third ventricle floor. We put deck forceps and create the stoma very carefully because it's very narrow. And then go inside because it's very small endoscope. So it's very easy to go inside and see what's happening inside of the interpedicular system. And restore, and very easy to restore circulation. All membrane we perforate, all membrane. Very easy, very easy. 6 clivus, and this is the end of the clivus. So now it's very depth inside. No other endoscope give us for us this possibility, only this polyrigid. And after we restore the CSF circulation more and more, very safely. So now we create ETV, even in this very difficult situation, even in this very narrow ventricle, even in this very scarred interpedicular system. After we create the septum pellucidum because it's a asymmetrical hydrocephalus. Now we create the septostomy and check the contralateral ventricle also. Delay the fenestration by the endoscope, the tip of endoscope. And then we remove endoscope from the brain, from the lateral ventricle. You see the postoperative, good flow, good flow. After 6 months, we check the patient. And remove the shunt. Patient shunt independent. Another also very difficult and very interesting cases. The patient have a history of also a lot of surgery, a lot of multiple revisions and replacements of the shunt system. Also, we made, after these revisions, we made ATV, and after ATV, we performed lumbar parietal shunt for this kind of patient. But after five years of good conditions, in 2019, we see the deterioration of the patient condition because the carry malformation deteriorate. You see in this MRI. So why we must decide what we must do next step? Because we must remove the lumbar parietal shunt. And after that, the standard we put inside of the brain the ventricular peritoneal shunt with the programmable wave. We hope what this operative procedure is enough for this kind of for this patient. But when we put the shunt to the ventricle, even we have programmable valve, even we have experience, even we have changed the pressure, not enough for this patient. And after some times, we have a lot of complications. You see the slit ventricle syndrome, typical. And
Albert, we have to move on. Please sum up. It's almost more than 30 minutes now.
Okay.
Yeah, we are more
very
than 1 hour behind.
Yeah, very interesting case, very interesting operation. Okay, I move. Okay, and this is a big hydroma also. What to do? So we make, we enlarge ventricle by the ultrasound control. You see, put inside through the shunt the fluid. We enlarge the ventricle after control of the ultrasound. And when we make re-ATV, even in this condition, you see obstructed shunt, Monroe. And then this is not easy, but possible. Very narrow. But when we put stent,
Albert, we have to move on, really.
okay, and then we put in interpedicular system. This is after operation, the up, efficiency, conclusion. So the use of more advanced endoscopic techniques, it makes it possible to restore CSF circulation, even in narrow ventricles and in slit ventricle syndrome. It's all of us to achieve the shunt independence in 80%. And even 35 shunt independent after endoscopic shunt surgery. It's possible also. Thank you.
Thank you, Albert. Please use the chat function to discuss every issues with Albert. I think it was a wonderful talk about the slit ventricle syndrome, which is a real problem in many cases. Well, we move on to the shunt scope, and Manas will present us his thoughts about it. Plus, Manas, please try to stay in time, 15 minutes maximum.
Yeah. Thank you, Professor Ottel. Can you please stop sharing your screen so that I can share your screen? Professor Sufiano, can...
Manas, I already stopped the sharing of Albert's screen.
Okay.
Yeah.
Can you see my screen?
Yes.
Sure.
Good morning. I'd like to thank Professor Borbas and Professor Nasir for asking us to present our experience on endoscopy. my talk is not on high-tech, many equipment which Professor Sufianov had shown. This is more which can be used in all the countries, especially low-income countries. All developing countries can use this system. The most usually means when we do shunt, what Dr. Sufianov showed, that placing the catheter is an issue. How to place the catheter in the proper place. There are, especially in patients with the multilocular hydrocephalus, where we do a septostomy and then we try to place one ventricular catheter which can cross all the loculi, all the compartments, so that we can finish off with one VP shunt instead of multiple shunt. Or a case like this with a large posterior third ventricular tumor with the whole third ventricle where is oblated with hydrocephalus, we plan to do a shunt where it was septostomy, and then we place a catheter which crosses both the ventricle. Similarly, in another case of a thalamic tumor with obliteration of third ventricle, where we planned a septostomy and endoscopic biopsy and a VP shunt, but we had planned that the catheters would be placed in both the ventricle. There are different ways of placing, but I'll present how we do it. Why it's important to place a catheter across all the compartments is because we do not know the septostomy closure rate. The literature is there is no paucity of literature in what is the rate of septostomy closure, but we know that the floor of the third ventricle, when it's perforated in hydrocephalus, the closure rate is almost 40% in post-op MR, and hence the success rate of ETV is only 40 to 89% depending on the age. So if you extrapolate the closure rate of the floor of third ventricle, even when you do a septostomy, in 40% of time to close, hence it's important to place a catheter, and just septostomy is not enough. So the aim is to place a ventricular catheter against in all the compartments, and how to do it easily with less cost and less expense. And also we know there was almost a half an hour discussion on the placing the location of the ventricular catheter tip, and the ideal position of the least infection is if it's in the frontal horn or in the body of lateral ventricle, not touching against the wall or against the choroid plexus, or in the occipital horn. And so it's important to have a proper placement of the catheter tip whenever we do not only a normal shunt, but also other multi-compartment shunts. There are many techniques which Professor Sufianov showed, an ultrasound guided. One can do an endoscopic guided, but place the catheter on the outer side of the endoscope, as he showed in his video, or one can use an stethoscope, or one can use navigation guided with electromagnetic stealth. But all those things need an additional equipment, and most of them are expensive, whether you're an ultrasound or a stethoscope or a navigation. Like when one uses an ultrasound, one has to do a little bigger burr-hole also to place the ultrasound probe, as well as the catheter has to be, the ventricular catheter has to be placed in another channel. So the burr-hole placement is larger. And image guidance, when one needs an image guidance, should be available there, and one has to have a pre-op MR, which increases the cost of treatment. So one cannot do with an optical, because optical, again, you have to fix the head. So electromagnetic is better. Using a stethoscope is ideal, where the stethoscope is placed inside the catheter, as Dr. Sufianov had shown in his case. But then stethoscopes are expensive, it's delicate, and one cannot let everyone use it because then the lifespan comes down. So the other easy way, what we normally do is along our shunt endoscope, we place the catheter along it. But then when placing it, the track is blind in all this till we reach the tip of the endoscope, and then it causes. And then placing it at the proper hole, then one has to manipulate the catheter, that causes cortical damage. So what we had learned in a cheaper way is to use the Fogarty catheter, fix the shunt, it's 15 centimeter to the tip of the Fogarty catheter, and then insert the Fogarty catheter with the shunt through the working channel of the endoscope. And then once you place it in the proper place, then the endoscope is withdrawn and the Fogarty catheter is detached from the tip of the catheter, and then it is connected to the peritoneal end. To see that all the compartments are covered, we make multiple holes, additional holes on the ventricular catheter, depending on the size of the catheter one has to place. And then, as I showed you in the picture, it is placed, the catheter is fixed to the Fogarty number 4. This is on the outside just to demonstrate how it is done. And once the catheter is placed to the proper place, and then the endoscope can be withdrawn from the butthole and the catheter is detached. This is how it is done during surgery, intraoperatively. We have already done a septostomy. You can see here, this is the septum. Instead of doing a bilateral shunt, we did a septostomy. We had already done a biopsy of the tumor. Then the Fogarty catheter with the attached ventricular end is inserted. And you can see here, it's very easy to place it into the opposite ventricle through the center of the septostomy. The vision is good, it's not eccentric. And then the endoscope is withdrawn with the Fogarty in place. And the ventricular catheter is held by the assistant, and then the Fogarty is disconnected from the ventricular catheter, and the ventricular catheter is connected to the lower end of the shunt. This is another case of a thalamic tumor where we did a septostomy as well as a biopsy. After septostomy, we went to the contralateral ventricle to do a biopsy of the thalamic lesion. Laser is used to coagulate, to make an entry point of the tumor. Instead of using a biopsy needle, we use an number 5 infant feeding tube. And the tip of the infant feeding tube is cut. All the holes are taken off. As you can see here, the infant feeding tube is used to do biopsy, to aspirate biopsy. And as you aspirate from, one has to do alternate clockwise and anti-clockwise rotation. So it acts like a true cut biopsy and you get a lot of tissue. Whereas one uses a biopsy forceps, it takes a lot of time. You get bits of small, minute pieces in order to do multiple passes. Whereas one uses an infant feeding tube number 5 and do like this maneuver and alternate clockwise, anti-clockwise. You can get a lot of tissue from the tumor in one go. It shortens the tumor, shortens the duration of surgery. And if there is any bleeding, one can again use the Fogarty catheter as a tamponade on the tumor to achieve hemostasis. You can see here that you're using the Fogarty catheter to achieve hemostasis. This is just showing the septostomy. Through septostomy, we entered the other ventricle to do the biopsy from the opposite contralateral. So we use the contralateral ventricle to do the biopsy of the thalamus. So this is another case, again similar, showing this doing septostomy and placing the ventricular catheter. Here it means the field of vision is in the center, not in the eccentric, as if you put it in the along or adjacent to the endoscope. We work through the working channel, and we are sure that how many holes you are putting in the opposite ventricle and how many holes in the ipsilateral ventricle. So there are many techniques to deploy ventricular catheter. You have ultrasound guided in shuntoscope or navigation, but using a Fogarty catheter as a ventricular catheter delivery device is a very cost-effective, cheap, which can be done at all theaters which have just an endoscope. In conclusion, this is the cheapest and most effective catheter deployment device. Thank you for your attention. I hope I finished in time.
Perfect. I think we move on without discussion because we're so far behind schedule. I'm sorry. We move on to the next Russian speaker. It's Sergey. Are you there? I haven't seen you yet. Obviously, he's there. We will talk about management of infected shunts. Please use the chat function to discuss all the issues. I'm sorry about this, but we are far behind schedule.
Thank you. Thank you, dear Joachim. Thank you, Professor Nasser, for invitation for this very popular seminar. It's a great honor for me to take part in it. So I work in the Burdenko Neurosurgical Institute. In my speech, I will try to fit in 15 minutes. So first of all, my great respect to Professor Morris Shooks, who contributed greatly to the prevention of infections in the ventricular peritoneal shunts. So due to his works, the level of shunt infections decreased from 15% to less than 0.2%. But in the majority of clinics, the incidence of shunt infections is about 3 to 10%. The brain shunts has the highest rate of the implanted medical device-related infections. Usually it manifests within first 6 months of implantation, and most in children under 2 years. I would like to stress that systematic antibiotic prophylaxis has a limited role in the prevention of shunt infection. So it is very necessary to know the risk factors of shunt infections. So there is the shunt risks are associated with a child. So this is the prematurity and low weight, recent myelomeningocele closure, prolonged intensive care unit state, and many others. You may perform a print screen of this slide or follow the recordings of this seminar. So the next group of risk factors are attributed to the shunt themselves. So this is the high-profile devices. So this is a prolonged exposure of shunt components to the operating theater room and repeated shunt tapping on shunt revisions. And the third group of risk factors are due to the environment. So it was already mentioned by many speakers that that you have to avoid the multiple previous surgeries in the same operating theater. So to limit the high operating room personal traffic, and to check the adequate climate control in your operating theater. So the diagnostics. CSF constitutes an excellent bacterial growth culture. So, and the majority of isolated organisms in cultured CSF from infected shunts reflect the skin flora at the implant sites. So in older individuals, we see the tendency to the gram-positive staphylococcal organisms, while in infants, to gram-negative fecal organisms. So the signs are related to the raised ICP, to the fever and irritability, to the wound inflammation and tenderness along the subcutaneous shunt tract. All of these signs are typical signs of chronically infected shunts. So as well, we may see the abdominal pseudocyst with mass effect and abdominal distension, which may be associated with the acute abdomen. So sometimes we see the spontaneous externalization of the peritoneal catheter. The laboratory tests are well known, and they are also described on this slide. I would like to stress that the newborns, that the laboratory analysis of the newborns differ greatly from the older children and from the adults. That glucose concentration is about 2/3 of blood glucose levels. This is a very important mark, and that the protein concentration may be due to inflammatory process in the ventricular system, but it persists very long after the negative CSF cultures. So it is the secondary mark of the inflammation. Concerning the MRI, we can see the ependymal enhancement along the intraventricular fluid level. And as well, we can check the pseudocyst formation in the abdominal cavity. So the CT, the MRI scans may show the brain abscess, which may be present along the tract of proximal catheter, but I think in rare cases. So now about the management. The main steps in the management of infection shunts are the removal of all shunts and catheters. Even they are very expensive. You have to take off all of them. So the infected hardware represents a reservoir for microorganisms. In case of raised ICP, the EVD placement should be performed at once. The distal catheter can be extravasate at clavicle level and attached to a sterile EVD drainage bag. And the systemic and CNS effects of the infection must be controlled with the broad spectrum antibiotics, which can later be tailored according to the culture results. So this is very important table where you can see that if we use antibiotics alone, that the curable level will be rather low. And if we follow all these main steps, we shall, our treatment will be very effective. So, of course, it is much better to avoid the shunt infection than to treat it. So several tips I will remind you, but some of them were already spoken about during this session. But nevertheless, I will try to stress that shunt system to be implanted should have the smallest profile and the least possible number of shunt compartments. The skin of the patient should be cleaned prior to being covered with a sterile adhesive plastic film. So a distal catheter can be inserted in a single passing from the head to the periumbilical incision. Care must be taken, however, to avoid a tear in the skin from the catheter pass. The trajectory of the catheters should be planned to avoid the areas of the tracheostomy, gastrostomy, or central catheter. Usually, we place the knots facing down or to the side of the valve catheter junction. So not to face them to the skin of a small child, because even these knots can erode through the skin of a preterm baby. So, and of course, the proximal and distal incisions should never overlay shunt hardware. So there was a question, the question concerning the no-touch technique. Yes, it is used by some of the neurosurgeons, but to my mind, it's not the most important one. But really, in this case, even the surgeon's gloves never directly touch the shunt. And a separate set of instruments should be used for the shunt assembly. Okay, now the treatment of infected shunts. So first of all, this is the changing proximal insertion site. So we have to insert the EVD first prior to removing the proximal catheter of the infected shunts through a different burr hole. It's a very important moment. This avoids excessive CSF loss through the tract left by the old catheter and ventricular collapse. Then we have to set the appropriate ICP. And again, pay attention that the infants differ from the older children. And at last, the laboratory CSF tests, we perform them 3 times a week, any other day. And we measure the glucose concentration, cell counts, and CSF culture. So some words about the complicated shunts infections. In some patients, we can face the abdominal pseudocysts. So in this case, may be recommended the externalization of the distal catheter through the incision below the clavicle. As for me, I dislike this method, but in some cases it may be used. Again, pay attention to the possible implications of the multi-organism infection. So if more than one microorganism is identified during the initial laboratory analysis, especially gram-negative, there should be a suspicion of a distal catheter perforating a bowel or a bladder. So these situations are shown on this list. Antibiotic therapy. So we use the systemic and intraventricular antibiotic therapy. So the most common microorganism isolated in the cultures from the infected shunts are the Staphylococcus epidermidis, Staphylococcus aureus, and gram-negative bacteria, mainly Escherichia coli and Klebsiella. So the duration of treatment is guided by the response, of course, but it should not be less than 14 days in general. So, and we await a third negative CSF culture before planning for the shunts reinssertion. This is the table of intraventricular antibiotic therapy. So this is the common question, which antibiotics we can use for the intraventricular injection. So this is the recommendations of the American Clinical Practice Guidelines. And so you may see all these antibiotics and their dosage shown on this slide. I won't repeat and read all this slide. So you may perform a print screen. So only several comments. So the most popular antibiotics are gentamicin and vancomycin. So, and the dosage recommendations in adults based on the ventricular size or volume. So as follows. So in the slit ventricles, in normal size, and in the enlarged ventricles, the dosage will differ. And the recommendations for frequency of administration based on the external ventricular drain output. So it also may differ. And we shall use the different dosage of antibiotics in this case. So, and in the to take home message, so if we use all these recommendations, we shall obtain about 90% success rate. What do we mean when we say about the success rate in the treatment of shunt infections? So it means that we have cured the shunt infection during 2 weeks. If it take more time, so something is wrong. And this is, we consider as a failure, but not for a patient, but the method of treatment for those methods which we have used. But I hope that all these patients should be treated, all of them. Okay, thank you so much. I think that I have fit in time. Thank you.
Thank you, Sergey. Excellent presentation. I think this is a very difficult and a very common problem, shunt infection. Please use the chat function. So we move on, and I hand over to Moody. Moody, are you there? I saw you already. So
Yes,
Moody is
very
going
much,
to
sir.
moderate the last session. Please.
Right. I think in the interest of time, we'll go straight ahead. It's been a fascinating 2 sessions on how to manage shunts, how to put them, how to place them. And now we have another 3 very, very interesting talks. The first one to start is on endoscopic treatment of complex hydrocephalus by our one and only Professor Nasser El-Ghandour, who has become a sensation in the world of webinar and education. Nasser, all yours.
Thank you very much, Mahmoud. For the sake of time, I speak today about endoscopic treatment of complex hydrocephalus. I have nothing to disclose. Simply, we define complex hydrocephalus. It is any form of hydrocephalus which cannot be treated with a single neurosurgical intervention. It is a difficult problem in pediatric neurosurgery. It can be classified into uniloculated and multiloculated. Uniloculated means a single cyst inside the ventricular system. Multiloculated means the presence of multiple cysts inside the ventricular system separated by multiple septations. It can be also classified anatomically into supratentorial and infratentorial. I also found another classification in the literature, which depends on complexity of the cyst and absorption capacity of subarachnoid space. However, it's not easily to be applied clinically. Etiology. Uniloculated hydrocephalus usually is congenital in nature, whereas multiloculated hydrocephalus can be due to neonatal meningitis, intraventricular hemorrhage, and post-operative gliosis secondary to shunt infection. The common factor between these 3 causes is the ventriculitis. It seems that the ventriculitis, whether chemical or infectious in origin, it will probably encourage subependymal glial tissue proliferation, upon which exudates and debris organize, and this leads to the formation of the septations. Look at this intraventricular hemorrhage. The consequence of its resolution is the formation of intraventricular septa. The message to young neurosurgeons who are dealing with these children: if you find disproportionate hydrocephalus in CT scan, please ask for magnetic resonance imaging. And gadolinium is very important, otherwise you'll not be able to recognize the septations properly. CT ventriculography is a definitive diagnosis. It can confirm that these cysts are not communicating with the ventricular system. As you can see that the contrast dye is filling the ventricular system bilaterally, which confirms successful fenestration. Stereotactic aspiration can be used, however, it is associated with high incidence of recurrence up to 80%. Multiple shunting, microsurgical cyst fenestration either through transcortical or transcallosal approaches, and finally, and recently, endoscopic treatment. What can the endoscope do in these patients? We can make endoscopic cyst fenestration, and it's a classic procedure: endoscopic shunt retrieval, endoscopic shunt revision, new shunt placement, shunt simplification. And when we say shunt simplification, it means that we are replacing multiple shunts by a single shunt. And finally, endoscopic third ventriculostomy. It's important to tell you that endoscopic third ventriculostomy, it is very difficult technically to be performed in patients with multiloculated hydrocephalus, simply because the anatomy is distorted. We started to operate on these patients 25 years ago, presented our results in San Diego, 2001. Then we increased the series of our patients. We presented again in Chicago, 2006. And then we realized that these 2 types are divergent types and they should be studied separately. Why divergent? Because the uniloculated hydrocephalus is congenital in nature with unaffected subarachnoid space, whereas multiloculated hydrocephalus is usually post-infectious or post-inflammatory with obliterated subarachnoid space. We published our first series in the neurosurgery. Look at this table. It shows the first study about endoscopic treatment of complex hydrocephalus, was from the United States, published 1995. The second study was from Poland, published 2003. Both studies included both types of hydrocephalus, uniloculated and multiloculated. The third study was from Egypt, and it was specific for the endoscopic treatment of multiloculated hydrocephalus. The fourth study was from Egypt as well, and it was specific for the endoscopic treatment of uniloculated hydrocephalus. This, our first study was published in the Journal of Neurosurgery. The second one about uniloculated hydrocephalus published also in the Journal of Neurosurgery. How to approach the problem? Our goal is to find out how to communicate all compartments with each other. Remind you that the disease has often not yet reached its final stage when the case is presented to you. And so expect a high incidence of post-operative recurrence or reclosure. The most important thing is the proper selection of the entry point, the proper selection of the burr hole, and the proper selection of the trajectory. I'm using a single burr hole, and I'm using different trajectories, and I can fenestrate as much cysts as I can. Of course, it's impossible to fenestrate all the cysts during the first operation, and it's normal to have repeated procedures in the management of these patients. Is it possible to avoid shunts in multiloculated hydrocephalus? The role of endoscopy is usually limited to doing fenestration. Patients usually still need shunt to treat the hydrocephalus. Why? Because the pathophysiological mechanisms that cause the septations are responsible about the deficiency of absorption capacity due to scarring of the arachnoid granulations. I'm using rigid lens, 2 mm diameter, wide angle, straightforward, with a working channel through which the instruments are introduced. As I said, that the entry point and trajectory should be properly selected, and they are crucial in order to ensure success of the procedure. Whether to go uniportal or biportal, I recommend doing the operation through a single burr hole, because I noticed that when I'm using 2 burr holes or more, there is the problem of air entering inside the ventricular system, which hinders the post-operative recovery of these patients significantly. You can use freehand or fixed endoscopy. I like to use freehand and the rigid endoscope due to the superior optics. Look at this diagram. It shows you if you properly select the trajectory, you can perforate a big number of cysts. Intraoperative findings, we have to know that the disease is complex in nature, and so you expect to find that the membranes are opaque, they are multi-layered, and they are usually couldn't be identified easily because the anatomy is distorted, and they are very tough, and so they couldn't be easily fenestrated. Localization is another important issue. How to localize? You can use ultrasonography, navigation. I mainly depending on multiplanar MRI with gadolinium. However, after becoming familiar in dealing with these patients and after developing a good learning curve, it will be possible to differentiate these septations from the ependyma. The septations are usually mobile with CSF pulsations. What about the size of fenestration? I recommend using a very wide fenestration so long that safety is ensured. Why? Because of the high incidence of reclosure. Why? Due to the low pressure differential across the cyst wall and because of the inflammatory origin of the disease. What are you going to do the fenestration? Are you going to use blunt or sharp? When we started to operate on these patients, we used the blunt perforation by the tip of Fogarty catheter. And then I realized that I was doing stretch over already stretched membranes, and this can induce more damage to an already damaged brain. And so I recommend doing sharp fenestration by coagulation, by bipolar coagulation. You can use scalpel or scissors in order to avoid stretching and damaging these membranes. And because the membranes are usually very tough. Which to do first, fenestration or shunting? I like to do both at the same sitting. However, I like to do fenestration before shunting, because if you do shunting, if you do shunting first and then you have some oozing or some bleeding during fenestration, the shunt will be obstructed later on. I don't like to put an external ventricular drainage except if there is bleeding. Why? Because I believe that it initiates cyst collapse and it initiates subdural effusion. It also interferes with the cerebrospinal fluid pressure gradient and this accelerates post-operative reclosure. Let me show you some illustrated cases. This is a child, 3-month-old, with huge intraventricular neuroepithelial cyst. Look at the post-operative imaging 3 months later on. You can notice that there is marked improvement of the hydrocephalus, restoration of the ventricular architecture, increase in the cerebral mantle, and opening of the subarachnoid space. Let me show you the video of this patient. You can notice that the cyst is bluish in color. We open sharp by using the coagulation. And after making the fenestration, you will notice that the cyst is collapsing. And you can notice that we already opened the foramen of Monroe. This is the foramen of Monroe. Restoration of the CSF pathways is one of the important targets of this operation. The intraoperative photos of this patient had been chosen for the cover image of the Journal of Neurosurgery. Another patient, 7-month-old boy with multilocated hydrocephalus due to toxoplasmosis intrauterine infection. Look at the post-operative imaging, and you can notice that marked improvement of the hydrocephalus. Another patient with the same patient. Let me show you the video of this patient. Now we are making the fenestration by the tip of Fogarty catheter. As I said, that blunt perforation is not safe. Look at the amount of stretch we are inducing over the already stretched membranes, which can risk more damage to already damaged brain. Another child with complex shunt and multilocated hydrocephalus. After endoscopy, simplification of the shunt was done, and you can notice marked improvement of the hydrocephalus. This is the same patient, and let me show you the video. We are now dissecting the adherent ventricular catheter under endoscopic visualization. The message to young neurosurgeons who are interested in dealing with these patients, please don't try to retrieve or pull adherent ventricular catheters in multiloculated hydrocephalus without having an endoscopic visualization and without making endoscopic dissection, because you can risk a serious intraventricular hemorrhage. And so retrieval is done by endoscopy, will be more safe. Another patient, and this patient had been operated through a biportal technique. As you can notice, post-operative imaging show considerable improvement of the hydrocephalus. And this, we use 2 burr holes, a left or a frontal burr hole through which we introduced the endoscope, and a left occipital burr hole through which we introduced this catheter. We were able to do endoscopic third ventriculostomy in this patient, as we can see from the video. We obtained the 75% improvement radiologically. Shunt was avoided in 12.5%. Simplification of complex shunts was done and was successful in 50% of our patients. Shunt revision rate was reduced from 2.9 per year to 0.2 per year. However, clinically, we don't have much information about the long-term clinical follow-up of these children concerning the brain functions or the quality of life. Morbidity included CSF leakage, minor bleeding, subdural hygroma. All complications were reversible. Recurrence was encountered in 33% of the patients. All of them were operated for the second time by endoscopy. Let me show one of the patients with morbidity and post-operative imaging showing bilateral subdural effusion. Look at this hemorrhage inside the ventricle with a fluid level, and look at this post-operative imaging 3 months later on complete resolution of the bilateral subdural effusion, and there is new septum formation, as you can notice here at the same site of the intraventricular hemorrhage. In conclusion, all patients in whom shunts were placed before fenestration required repeat endoscopic cyst fenestration. whereas none of the patients in whom endoscopic cyst fenestration preceded shunt placement required shunt revision. In other words, patients who have shunts placed before fenestration had a 7.5-fold risk of having repeat endoscopic procedure, more than patients in whom endoscopic cyst fenestration preceded shunt, which makes a clear conclusion that early diagnosis and treatment gives the best results in managing these patients. And this can be attributed to the thinner septations, easier fenestration, less vascular cyst wall, and less likelihood of reclosure. Of course, fenestration gives better results in uniloculated than multiloculated hydrocephalus. I would like to emphasize that when you have a disease which is complex in nature, that treatment will be complex in nature as well, because people may think that communicating these cysts solve the problem. Unfortunately, that's not the case. Why? Because most of these patients are infants with immaturity of the subarachnoid space because of the deficient absorption capacity of the cerebrospinal fluid as a result of scarring of the arachnoid granulations, and because of the inflammatory nature of the disease, there will be progression or regrowth of the membranes with high risk of post-operative reclosure or recurrence. We are organizing hands-on workshops about endoscopy in Egypt. This is gathering photo with the president of the past president of the World Federation and the faculty and all attendees. Another course was organized in March 2019. We are offering scholarships for candidates from LMICs. Thank you very much for attention.
Thank you very much, Nasser, for that masterclass. As always, superbly articulated and really a very, very fine example of how webinars can be very useful in teaching all across the various levels of practitioners that attend these webinars. We're already 30 minutes past time, and it's a pleasure to introduce our next speaker, who's going to talk to us on endoscopic versus shunt for infant hydrocephalus, the current state of debate. There is no doubt that whenever such a topic is to be discussed, Abaya Kulkarni's name is amongst the leading group. He's done a lot of work based at the Children's Hospital in Toronto. And really, it's a pleasure to introduce Abaya to once again listen to all the wonderful and academic work that he has put together to assist in us deciding how best to treat this very difficult condition. Abaya?
Thank you so much. Thank you. Very, very kind introduction. I appreciate that. Thank you. It's a real pleasure to be here, and I thank you for the invitation. I will talk about endoscopy versus shunt for infant hydrocephalus, which I really think is one of the major debates that has been going on for many, many years now, and it's an evolving debate, but remains an unresolved issue. And you know what it comes down to, we always ask this question: is ETV better than shunt in infants? And part of that, though, before we can begin to answer that, is we have to define what outcomes we're looking at. When we are going to define better, what outcomes are we going to be considering? And for surgical failure, need for repeat surgery, that's a major outcome which we've looked at traditionally for many, many years. But quality of life is also important, and so we'll look at both of these in turn. So if we first look at surgical failure and the need for repeat surgery, what do we know about comparing ETV and shunt in infants with respect to surgical failure data? Well, there's not a ton of it that's out there. This is data that we had collected from multiple centers. This is non-randomized data, so that's very important to keep in mind. This is non-randomized data. These were all patients who were selected by their surgeon to have ETV or shunt. And if you just look at this, you know, non-randomized, all age groups, you have the sense that, you know, maybe there's some benefit longer term to ETV. This is now 24 months, 2 years after treatment, and this is failure-free treatment success. But what it hides is that there's differences here amongst the groups. And so if we look to infants, and let's start with the under 2 years of age, then, early on, ETV looks less favorable, and then maybe it catches up after. But if you look really closely at the major infant group, because infant, it's sort of less than 2 years, but the majority of infant hydrocephalus that we see is typically under 6 months of age. They're very young. And when you look at that specific group and you try to balance confounding factors, this is what you end up seeing here, where shunt does appear to have, at least in terms of this non-randomized survival data, a clear advantage over ETV. We're looking at almost 22% absolute difference in 1 year survival, and that's a number needed to treat of 5, which means that for every 5 shunts that you perform, you would have saved 1 extra infant surgical failure from having done an ETV. So that's pretty important. But that again casts the whole infant group in with one brush, really. And there are subgroups of infant hydrocephalus. And so can we identify, are there any favorable subgroups where ETV might actually be of real benefit compared to shunt, even if on the large scale, that's not the case? Well, the International Infant Hydrocephalus Study looked at a particular subgroup of patients who, I think we believe could be that subgroup, because these were infants with pure aqueductal stenosis. So they were under 2 years of age. They had pure aqueductal stenosis as the cause of their hydrocephalus with no other major brain anomalies. They were not premature, not myelomeningocele, and a whole bunch of exclusion criteria. So it was a very clean group of patients. And the eligibility criteria were independently adjudicated for this prospective study. And this is what we found in that. So again, under 2 years of age, pure aqueductal stenosis. It still looked like that shunt had some benefit, not as much as what I showed you before, but 15% difference in the treatment success at several years out. This is now 3, 4, 5 years out. This is long-term prospective data. But again, this is, even though this is a relatively homogeneous group with all pure aqueductal stenosis, we can look more carefully and see that for those under 6 months of age, the difference is back what I showed you before. Remarkably, the exact same number, 22%, even though this is a completely different patient cohort, completely different database. Still, we show that 22% difference in favor of shunt compared to ETV for treatment success. However, what that hides is this. The corollary of this is that if you're over 6 months of age with a pure aqueductal stenosis, there weren't many shunt patients in this group, but this represents 40 ETV patients. That's about an 80% success rate. That's, I think, really good. And as you can see here, at least compared to the small number of shunt patients that we had, it was very, very similar. So this may be a subgroup that actually does very well, pure aqueductal stenosis and over 6 months of age. So, is ETV actually better than shunt in infants? Well, for surgical failure overall, the answer is no. But there are probably limited subgroups where ETV might do as well as shunt. Now, what about quality of life? This is something that we often don't measure just because it's harder. It's a lot easier to measure surgical failure and create those survival curves that I showed you than it is to measure quality of life. It's more effort, it's labor intensive, it takes time, families have to cooperate, but it's important. Because it is sort of, you can view it as the final common pathway of our surgical interventions and all the complications that ensue. How often the procedure failed, how often the child has to be in hospital, what level of anxiety and concern the parent and the patient themselves have, and ultimately dictates their ability to lead a normal life, which is really the ultimate goal of our treatment. So that's what quality of life is. This is the ultimate goal of our treatment. And I won't go, because of time, I won't go over in detail the various studies, but we've done a number of large retrospective studies in the past. And the overall conclusion of those is that we have not seen an obvious quality of life benefit to ETV over shunt. And that I think goes against most of our intuition. And I'll talk about this at the end, but most of us have a sense that ETV patients should be doing better than shunt patients. And I'll talk at the very end why I think we're biased in that assessment, because the studies have not borne that out. But we also have, that was retrospective data, but we also have prospective data from that International Infant Hydrocephalus study. And this study, we had 158 eligible patients, but we followed them for many years. And by 5 years, we had a lot of dropouts and loss to follow-up, but we had nearly 60 ETV patients and nearly 20 shunt patients who we had 5-year outcome on. So these were patients that we operated on when they were less than 2, and then we followed them up to age 5. So this is the best prospective data we have on long-term outcome in this subgroup of infant hydrocephalus. And You can see here that the ultimate results of this at 5 years was that by any measure of quality of life, there was no statistical difference between shunt versus ETV. And one thing that I can tell you, though, is that this group of patients, again, pure aqueductal stenosis, they had a very good outcome overall. These numbers are very similar to what you'd see in the general population. Okay, so these are very high functioning kids doing very well overall in life. We did notice that the cognitive score seemed to be better for shunt versus ETV. It wasn't statistically significant, but that's a reasonable difference of 0.1 there, even though it wasn't statistically significant. And we looked at that a little bit closer because we questioned, obviously, was it ventricle size? Is it the fact that the ETV patients had persistently large ventricles? Was that negatively impacting their cognitive outcome? Well, we threw in ventricle size as one of the variables in this model, and it really didn't change anything. It didn't change any of our results, and we did not find that ventricle size was a significant independent predictor of 5-year outcome. Now, one area of quality of life that has been shown to be different in patients who've had ETV versus shunt is that the parents of those patients who've had ETV show lower levels of parental concern and anxiety. And that's, of course, we view that as a very positive thing, right? We want our patients and families to be happy and to not be concerned and anxious about stuff. But that's a double-edged sword to some degree, because I think we're all aware of cases like this. And this is the study that Jim Drake compiled of ETV patients who many years after treatment had a sudden deterioration and in many cases died. And when you look back at the history of these patients, anecdotally, you have the sense that it may be because their parents were so unconcerned about their hydrocephalus treatment that the kinds of symptoms that they had in the days leading up to their death were the kinds of things that a shunt family would never ignore. They would bring them to hospital because they're vomiting or have headaches. But with an ETV family, some of them stop thinking about the hydrocephalus. They think it's cured and they're not worried about it. And then the child just doesn't wake up the next morning. So it has its own dangers. So, is ETV actually better than shunt in infants? We've talked about surgical failure. And I think for quality of life, the answer is probably not. Again, goes against our intuition, but the data does not bear out that ETV improves quality of life. Now, the new thing here, or relatively new, is whether choroid plexus cauterization changes the equation. Is this a game changer? And of course, this is a procedure that was developed in Uganda by Ben Worf and has been popularized in many low and middle income countries, and now is being quite popularly used in North America. And my sense is less so in Europe. I don't know about other parts of the world, but I think there's a greater tendency for this to be used in North America as compared to Europe, at least based on my discussions with my colleagues across the Atlantic. But does it make a difference? Does it change the equation? What we know from the extensive experience of Ben Worf and the Uganda group is that CPC does improve the chances of ETV success across a wide range of etiologies seen there, including congenital idiopathic hydrocephalus and congenital aqueductal stenosis. There appears to be a dose response effect, so that the more choroid plexus cauterization that you do, the greater the chance of success of the ETV. In myelomeningocele patients, they showed no difference in early cognitive outcome between these two procedures. And if an ETV CPC fails and then you have to put in a shunt, the survival of that shunt doesn't appear to be significantly different than if you'd put the shunt in the first place. Now, we studied this more formally. We did a randomized trial in Uganda, and this was looking specifically at post-infectious hydrocephalus. So just what is a large subgroup in Uganda, but a relatively small subgroup in many other parts of the world. Nevertheless, within that subgroup, we showed that there was no significant difference in 12-month developmental outcome between ETV, CPC, and shunt. You can see here the survival curve shows a non-significant benefit to ventriculoperitoneal shunt. We continue to follow this patient group up, and at 2-year follow-up results are very similar. No significant difference in cognitive outcome or in any major surgical outcome at 2 years. Now, what about in North America? And again, I'm looking. I know this is a very international audience, but I'm talking about North America specifically because this is where a lot of the non-Uganda, non-African experience has come from for ETV CPC, and of course, just by the nature of my practice, it's what I'm most familiar with. There's a lot out there, but I'll talk about the major highlights, of course, is what Dr. Worf has done since his returning to practice in North America, primarily in Boston. This is his latest series of 215 ETV CPCs and 73 shunts in infants. His etiology breakdown is very typical of what we see here in North America. And as expected, the vast majority of patients were under 6 months of age. And what he showed here is if you look at this solid blue line and the solid red line, in his hands, he was showing actually a non-significant benefit to survival for ETV CPC compared to shunt. That's a tremendous result. And in fact, when he went and redid some of these failed ETVs, he further got long-term success such that the majority of the patients in his group, nearly 70% of them, when he started out doing an ETV CPC, were able to remain without a shunt long-term. That's a tremendous result. But we question, he is the expert in it, right? This is his surgery. He does it better than anybody else in the world. And how transferable are his results to the rest of us? And so within the Hydrocephalus Clinical Research Network, which is a multi-center group in North America, 14 centers across Canada and the United States, we do a number of prospective studies of hydrocephalus. We've looked very carefully at this. We're very interested in what the role of ETV CPC would be in our North American patients. And you can see here the number of cases that we did by calendar year across the network. And this I show you this because 2013 is when we took a huge jump. And that was because that was a year that many of us went to Uganda to learn from the surgeons there, not just from Ben Worf, from Peter Senyonga, John Mugamba, and others who were there, to learn how to do this procedure. And then we brought that back to North America. And that's when we really started doing a lot of these. And since then, we've been doing close to 100 of these cases a year across the network. So we've developed a large experience with this. This represents sort of the first big analysis of our early experience. And you can see here that our results, are certainly not as good as Dr. Worf's results. And that may be for two reasons. One is obviously this was an early part of our experience. So we were still learning the procedure. There was a technical learning curve for us, but also it may come down to patient selection factors. And I think earlier on, we were less discriminant about the types of patients that we offered this to. So it would not be unexpected that our results would not be as good. We've since learned and are refining our criteria for this. But nevertheless, we showed about a 40% success rate for this, this procedure. And when we tried to match this with a shunt cohort, you can see here that the results really clearly favored shunt. This is, again, not randomized. This is non-randomized data, but you have the sense that this procedure, at least in terms of failure rate, in our hands in North America, was not doing as well as shunt. So we're still at a phase now, I think, where we're learning, and I emphasize that those were our early results, and I know that our results are better now. And right now, our general current indications are for infants, myelomeningocele patients who are term corrected age or above. The small subset of preemie IVH patients who are greater than 6 months corrected age. That's obviously a very niche group of preemie IVH who would make it to 6 months corrected age before needing treatment. And then most other patients were at least considering ETV CPC when they're over 1 month corrected age, as long as they have favorable third ventricular anatomy and there's no obvious prepontine adhesions. That's a very important risk factor for them. So we look very carefully on detailed MRI sequencing to make sure. Major questions for ETV CPC in North America remain. And I think for me, the two major questions, one is that, is there a minimum age under which the success rate of this procedure is just too low to even consider it? Because the risks are there of this procedure. I don't have time to go over them, but we've looked very carefully at that there are risks with this procedure for sure. And for what etiology should this not be offered? Are the risks too low? But that's a question we can ask ourselves, but what's more relevant is how the parents are going to answer that, right? How low a success rate are parents willing to tolerate for the possibility of shunt freedom, rightly or wrongly, right? Whatever, because they'll have biases that they bring into this based on Facebook groups that they've been on and stories they've heard about shunts or ETV and stuff, and they'll come in often just saying, before I've ever seen them, they want ETV CPC. And maybe the child's not a good candidate, and we have this long discussion that's largely educational. Well, we're hoping within the Hydrocephalus Clinical Research Network to better answer this question, because all I've shown you right now is retrospective and prospective non-randomized data, but we're working now on randomized data. So this is a large NIH-funded trial that's very similar to the one I showed you from Uganda, but now using that same template for North American patients across Canada and the US, comparing ETV-CPC to shunt. It's a wide-ranging etiology of patients. We are excluding preemie IVH, but really all other types of infant hydrocephalus are included. And very importantly, although we will be looking at surgical failure, it's the 12-month cognitive outcome that we'll be looking at. And right now, to date, we've enrolled 24 patients. So is ETV-CPC a game changer? Maybe for a subgroup of infants, but we still need a lot better data. I'm just going to end very quickly by just talking about surgeon bias. So the psychology of ETV-CPC. And this is something that I recognize in myself. And I'll just, as I mentioned this, I don't want to impugn the rest of you, but think about it. I think there's an inherent surgeon bias towards ETV, and some of this is pretty obvious. You know, obviously for us as surgeons, it's technically a more appealing procedure, right? You see the anatomy, it's a funner operation, if we were to put it in very colloquial terms. We like to do it. So that's an inherent bias. But also, when we think about shunts, you know, that first picture that comes into our mind is probably the most recent shunt disaster patient that you've had, who's been in hospital for weeks or months with infections and other complications. And they live in our memories in a way that ETV disaster patients don't, because ETV disasters are generally limited to major intraoperative catastrophes, which are very rare. But the fact is that when the reason we don't have these ETV disasters that long live like this is because once ETV fail, they go to shunt, and then they become potential shunt disasters. And if you were to look at this graphically, you know, you've got infant hydrocephalus, a small subset of them may be treated with ETV, and those that fail end up becoming shunt patients, some of whom fail and some of whom become disasters that we think about forever. And that's how we think about shunts. But, you know, what we forget is that while yes, there are patients who have success with ETV, in the grand scheme of things, that's a pretty small group of patients, you know, because most of our patients who are successful with shunt, and they actually do quite well. We just don't think about them a lot. We just end up thinking more about these. So it's just something that I try to remind myself about when I'm trying to decide or recommend one of these procedures or not to a family, and just something that I think is interesting to think about. And with that, I will end and thank you for your time.
Thank you very much, Baya, for that excellent talk, discussion, and the nuanced thinking behind how one makes a decision. It's always tricky, but you've, through your talk, made it as reasonably easy to understand for some of us. Thank you so much for taking that time. I think that what I would encourage is people to answer their questions on the Q&A and on the chats, please, because otherwise we'll be here forever. But that's not a bad thing. It's a lovely discussion and a really enjoyable educational webinar. It gives me now a pleasure to invite Frederick Boop, who's going to talk to us. I had to read this topic 2 or 3 times to understand. Maybe he'll make us understand it better when he says preventable shunt malfunction rate, and how the initiative of a quality improvement is to be put in place. So Fred is no stranger to any of our audiences. He's been on almost every webinar involving pediatrics and others. And Fred, it's always great to hear you speak. So over to you. Thank you very much for joining.
Well, thank you, Moody. And can you hear me?
Yep.
And congratulations to Nasser and Louis Borba for a fantastic morning. We've heard lots of interesting discussion today, and I'll try to wrap it up with this talk. If we're going to do better in our patients with hydrocephalus, we've learned from medicine in general that we need to look at quality improvement over time. We need to track and trend our results and look at ways in which we can improve the outcomes of our patients at every center, and not just rely on what's published in the literature, because it may not apply to where we are at home. So I'm glad that Abaya introduced you to the HCRN, the Hydrocephalus Clinical Research Network. This is an NIH-funded multi-center consortium that has done beautiful work in increasing our understanding about hydrocephalus and its treatment over the last decade and a half. So this is a paper from the HCRN looking at quality improvement and the use of a standardized algorithm for managing shunts. And this is 21 neurosurgeons from 4 centers, 1,500 shunts inserted over a 2-year period of time, minimum follow-up of 6 months. And what they were able to demonstrate was by adopting a standardized algorithm, they were able to demonstrate a relative risk reduction of shunt infection of 36% in their patients. And they were able to demonstrate some of the things that factored into shunt infections. So the highest contributor to a shunt infection is a prior history of CNS infection, whether it be an EVD infection, a prior shunt infection, prior meningitis, et cetera. And in those patients, they had 11% incidence of reinfection with shunting. The use of a BioGlide catheter, which is a slick catheter that I believe has been taken off of the market now, and I don't know why that was important. But also nowadays, it's popular to use this rub-on hand lotion that you can put on your hands in 30 seconds before you go to the OR, as opposed to a 7-minute scrub. And that was shown to have an increase in infection risk of almost 5-fold. So standard scrub, avoiding prior infection when you can. And this is the HCRN protocol, if you can read it. A sign on the door to limit traffic, position the patient's head away from the door so that any air that comes through the doorway doesn't carry airborne bacteria. Antibiotics given intravenously at least 30 minutes before skin incision, clip hair rather than shaving hair, remove dirt, debris, or adhesive material from the skin prior to draping, using ChloraPrep and letting it dry before you drape, and then scrubbing hands with betadine chlorhexidine rather than using the rub-on quick preps. Double gloving comes from a study by Jim Drake, and it was very interesting. He had everyone take their gloves off at the end of shunt surgery and fill the gloves up with water at the scrub sink. And they found that even though it's a relatively short surgery, 50% of the gloves had holes in them at the end of shunt surgery. And that's where the recommendation for double gloving came in. Protecting the skin with an antibiotic impregnated drape, such as Ioban or Bactroban, limiting exposure of the skin to the shunt material, given that most infections are caused by shunt, the patient's own skin flora, making sure the antibiotics are in. In the early iterations of this algorithm, they recommended intrathecal antibiotics in each case. We've certainly quit using intrathecal antibiotics, or at least I have, in the advent of antibiotic impregnated shunt tubing, and have not recognized a difference. And then techniques, spending time with the closure. As was mentioned earlier, it's typical that shunt surgery is relegated to junior house staff, and oftentimes the final wound closure is left to the intern or the medical student. And as you'll see in a minute, one of the causes of a preventable shunt complication is wound closure. So when we look at really what is most significant in this algorithm, patient away from the head away from the door almost meets significant, but certainly proper hand washing by all members of the surgical team and double gloving seem to be the most significant in reducing shunt infections. John Kessel will tell you that it's important to have a standardized algorithm that everyone understands and that all surgeons at the institution adopt. And this is certainly more critical than the elements involved in the algorithm. Now, this is another study from HCRN looking at factors that are associated with shunt infection and malfunction. And this, again, 6 centers, over 1,000 shunts inserted, 102 documented infections. And the significant factors associated with shunt infection, again, are a prior history of infection, a prior history of recent surgery, the presence of a feeding gastrostomy, and prematurity or young infants having higher complication rates. And as you can imagine, if your skin is 2 or 3 millimeters thick versus a centimeter thick, you're going to have more infections associated with it, more CSF leakage, et cetera. So no surprise here. But one of the important things to note is, of all the things that we look at when we talk about shunt infection risk, demographics of the patients, type of insurance status, whether they have government insurance versus private insurance, age, gestational age, birth weight, age at the time of surgery, etiology of hydrocephalus, gastrostomy, tracheostomy, every one of those things are things that are not modifiable by the surgeon. Those are problems that are brought to us and we don't have the ability to do anything about it. And so this is a paper that my partner Paul Klimo published a couple of years ago, looking at what he called the preventable shunt revision rate. And this paper was awarded Pediatric Paper of the Year by the Congress of Neurological Surgeons. But what Paul did was just this. He said, if we're going to consider shunts and treatment of hydrocephalus as something that we can improve upon, it will be a quality metric, then it has to follow the 3 M's. What we measure has to make sense, it has to be easily measurable, and it has to be modifiable. So looking at things like the patient's age at the time of surgery or history of prior infections are things that we can't do anything about. So we can't improve upon the quality of our surgery if we're dealing with issues that we can't control. So Paul conducted a multi-center trial, 9 centers, over 5,000 shunts placed in 2 years, and then followed looking at the 90-day failure rate. And they had 861 failures within 90 days, 17% median failure rate at 90 days. 35% of those met criterion for a preventable shunt revision rate, something that we could do something about. The most common preventable shunt revision problem was infection, and that made up 44%. And then 27% were due to catheter malposition, either a malpositioned ventricular catheter or a malpositioned abdominal catheter. And so again, if you look at all of these factors that were measured in this study, the vast majority of these factors are beyond the surgeon's control and something that we can't improve upon if we want to lower our complication rate. But when we look at the preventable shunt revision factors, again, infection was number 1, wound breakdown, number 2, position of the proximal catheter, number 3, position of the distal catheter, number 4, improperly assembled shunts or secured shunts, a shunt that either comes apart following surgery or slips out of position and has to be revised, and then judgment error. And when we look at the incidence of these 90-day shunt revisions across these 9 centers, you can see a doubling of complications in some centers compared to others, even at the best centers in North America, centers that have fellowship-trained pediatric neurosurgeons with a long history of shunt surgeries, very experienced. So looking at the shunt, preventable shunt revision rate, infection number 1, and this study I've included because it's probably one of the better studies we have. This is Connor Malucci's BASICS study, which is a prospective randomized clinical trial comparing standard shunts versus antibiotic impregnated shunts versus silver impregnated shunts in patients of all sorts from birth up to 91 years of age receiving their first time shunt insertion, and then followed for an average of 22 months, almost a year, a minimum of 6 months follow-up. The patients and the investigators were blinded as to treatment group. Obviously, you can't blind neurosurgeons as to whether they're using a standardized shunt or an antibiotic impregnated catheter. So they were not included in the analysis, but this was an intention to treat analysis. Primary outcome was shunt failure due to infection. Secondary outcome was adverse events of other causes. And what he demonstrated was equal enrollment across the three groups, 32 infected patients, 6% in the standard group, 2% in the antibiotic impregnated catheter group, 6% in the silver group. So these two groups fared about the same, but there was a significant reduction in infection in the patients who received antibiotic catheters. We've heard earlier today, some people question the use of antibiotic impregnated catheters because they're more expensive, and that can become a significant issue in some of the LMICs. But this is a nice analysis of cost by Matt McGirt and his group, looking at shunts and EVDs that have antibiotic impregnated plastic. And what they demonstrated is for VP shunts, out of 100 patients, they had fewer deaths by 0.5, not much, but 71 fewer hospital days, 11 fewer surgeries, and over $100,000 savings by using antibiotic impregnated shunt tubing. When they looked at EVDs, even more significant, 2.7 fewer deaths per 100 patients, 82 fewer hospital days, and $250,000 US in savings by using antibiotic impregnated plastic. And their point is that even though the individual catheters are more expensive, the net savings to the healthcare system justifies their use. So recommendations I might make to people doing shunts. Number one is there are so many different shunt systems, and it's not uncommon to see centers that have a dozen different shunt types on the shelf. This is confusing to the operating crew. It's confusing to the radiologist. It's confusing to the ER physicians when they see shunts of various types and don't know what they are. So I recommend finding a shunt that you like best and using it the majority of the time. As we heard earlier today, 95% of children will do fine regardless of the shunt type. And then having an array of specialty valves, if you would, other shunt types for the problem patients when they need them. We know from John Kessel's shunt design trial, looking at 3 different shunt types that have significantly different flow characteristics, that in a randomized prospective fashion, there was no difference in shunt malfunction amongst those groups. Use the standardized HCRN protocols. If you need to adopt them to your own institution, that's fine, but having a standardized algorithm is the most important part. We now routinely use frameless stereotactic navigation for placement of the proximal catheter to avoid the malplaced proximal catheter. For complex abdomens, children that have had multiple abdominal procedures or necrotizing enterocolitis, we're quicker now to involve our pediatric surgeons and have them laparoscopically place the distal catheter. If we have an infant that's had a recently placed feeding gastrostomy, we'd like to wait 2 or 3 weeks for that to mature before we place a shunt into the abdomen, and that seems to have helped reduce distal infections and abdominal pseudocysts in that population. We now routinely reuse antibiotic impregnated catheters. And importantly, we maintain a hospital database with our quality improvement team where we track and trend all shunt operations, looking at the cause of shunt malfunction and infection, and studying these as a quality improvement measure within our hospital. So in conclusion, people die from shunt malfunctions. If we look at patients with shunts, the published mortality is about 1% per year for an individual who has a shunt. Shunt surgery shouldn't be relegated to the most junior member of the team. Tracking our shunt surgery results should be a quality improvement initiative at every hospital. The adoption of a standardized algorithm across all surgeons at a hospital is important and will reduce the complication rate. Antibiotic impregnated shunt hardware can save money for the hospital, even though it's typically more expensive. And in experienced hands, as we've seen today, the infection rate across the institution should be below 5% in the current era. Thank you very much for inviting me to participate in this symposium.
Thank you very much, Fred. Thank you, Abhaya, and thank you all for the last session, which was spot on time, really. And for that reason, I think it's only fair that if there are any questions from the panel, we allow that. We will again request that the Q&A session be looked at by individual faculty and kindly answer those. But if there are any questions from the panelists and the faculty, please feel free to ask on this last session, which has kept on its time. Are there any comments? Everything very clear then.
well, maybe as a very small comment that I learned early on in the 80s when I was developing a new kind of shunt with an engineer checking multiple shunt systems. After a week, he came back and said, "You're not telling me you are actually implanting these?" So from an engineering standpoint, and then this humbling comment that he said, the fact that 95% of your patients are doing well probably shows more the flexibility of the human body to adapt than to any technical sophistication of what you do. So and I think that we should keep that in mind, that it's incredible how you, because it does not even closely resemble the normal circulation when we put in a shunt, but it has completely changed the hydrocephalus as a disease. And nobody of us has ever experienced that, what was still up to the 50s and the 60s before shunts were common. It was a fatal disease, and the shunts have really changed this completely. And I think without neurosurgery, it would be unthinkable without all these shunts that we have and the possibility to do so. And it is so great to see that with simple measures, you can still improve this for your individual patient. And that is what everyone should think, no matter where they are located.
Absolutely a valid point. When we first went into neurosurgery in sub-Saharan Africa, if a patient had moderate to severe hydrocephalus and had a meningomyelocele,
it would stop.
There's no merit in treating them.
Yeah.
And we, because of shunts, have seen so much benefit in these patients. That it's become gratifying to go and do a mission just treating hydrocephalus because of that. And we see it all across where we go and do missions to treat hydrocephalus, just with shunts and sometimes with ETV. So you're absolutely right, Andre. Any other, Louis, you were going to make a comment as chair of the education committee, please.
First, to say that I really enjoyed this morning here. Wonderful speakers, wonderful presentations. And the most important is that we are going to the same direction. See, we are trying to do the best with high technology, with the low technology. Is the way that our education committee want to work, to show the reality around the whole world. Thank you, all the speakers.
Thank you.
But I have one thing in my mind that I give to the young residents here.
Yep.
Please read the chapter of the surgical technique of shunt with the same flavor, same passion that you read the chapter of Kernel approach, of Petrozo approach, of the temporal approach.
Sergey, you have your young neurosurgeon. Does he want to make a comment on your behalf?
And the second is say that in the operating room, everyone inside is the focus of infection. Watch out and take care of not only your surgical technique during the act, but the whole environment. It is really make the difference. Thank you very much, Professor.
Thank you very much.
Thank you.
Thank you. Thank you very much.
Sergey Jr. Bye-bye.
Thank you, Mahmoud. Really thank you. Thank you very much for everything. And thanks to all speakers, to moderators. Thanks, Louis, for this great opportunity. And see you again shortly in another occasion. Thank you very much.
For sure.
Thank you very much, everyone.
Bye-bye.
Thank you. Thank you, Nancy. Thank you. Thank you, Tito. Thank you very much.
Thank you.
Bye.